Good morning, all. I welcome you all for the fourth alumni reunion of Optaa. Let's begin this event with a word of prayer. Let's pray. Lord, Heavenly Father, we thank you and praise you, Lord. We thank you for helping us to gather here and to worship your name, Father God. Lord, thank you for giving us this opportunity to stand here, Father God. Lord, thank you for helping us to make this event happen, Father God. Lord, I pray for all the students and alumni who are present here, Father God. Thank you for bringing them safe here, Father. Lord, as we are starting this event, Father God, let your presence go before us. Make all the crooked paths straight, Father God. And Lord, whatever has been taught here, help us to understand and practice in our lives, Father God. We submit today's question into your mighty hand. In Jesus' most precious name we pray. Amen. Yeah, thank you. Handing over to David, sir.
Good morning, one and all. A warm welcome to all who gathered here. It's nice to see you all. Nice to see some of our seniors and friends after a long time. It's a pleasure to have you all today for this fourth Optaa reunion. So for people who don't know, I mean, the students who don't know when Optaa was started, we started in informally Optaa reunion. We had one in 2001. The second was in 2011, where we officially launched Optaa in CMC. And that was the second reunion. In 2016, we had another one. And this is the fourth Optaa reunion that we have here. And we warmly welcome all the students. And for your information, like the expenses for the CME, for the students, the lunch, everything is being taken care by the generous contribution by the alumni. So everything is covered. So hope this whole CME will be a fruitful thing and you will be able to learn. So without much delay, we'll go on to the CME. The first session is on pain perspectives for rehab professionals, shift in trends. So the speaker for this session has got about 26 years of expertise in the field of pain management and hemophilia. Right now, he's the founder and co-director of Charlie's Spine Clinic in Velo. And also, he's got many publications to his name, and he belongs to the batch of 94. Without much delay, we welcome Mr. Charles Premkumar, batch of 94 PT, to take over the session.
Thank you so much, David. And thanks everyone for the warm welcome. It is indeed an honor for me to stand here this morning to be part of this fourth Optaa CME. And I've been tasked to present and share with us pain perspectives and certain shifts in trends. I want to thank the organizers for roping me in, and I want to also acknowledge the presence of many of my seniors and my own teacher, Andrew sir, and departmental heads. My batchmates are here as well, and so it's a wonderful time for us to meet together. My forever classmate and forever class representative, Sundar, must be somewhere there. And Shivram is there, Preethy Finney is there, and it's an amazing time for me to be in their midst and also to share some perspectives that I learned along the way. So this is how I've titled it, and I'll try and keep it less technical so that we get the gist of what we need to know for us to elevate our pain practice. So here we go. Ida Rolf is a very famous name in the field of pain practice. And she said, where you think it is, it ain't, it isn't. So a little overview of what I'm going to speak on. I'm going to touch on pain theories very, very briefly. Don't get scared. I'm going to also touch on pain categories, pain structures, and pain practice. And I want to highlight the shift in trends that we all should be aware and cognizant of in our own clinical practices as rehab and pain professionals. Pain theories. If you look at the timeline, pain is something that is as old as humankind itself. Thanks to Adam and thanks to Madam, that's what the worldview from which I come seems to be suggesting. Now, initially, in the year 428 to 342 BC, there was a theory of pain that was floating around. And then for a long time, there was another theory that was in vogue. And in 1644 is when a major breakthrough came in with the dualistic theory and then the specificity theory, gate control theory that most of us would be familiar with, and then the neuromatrix model. So the timeline is very vast. From the time mankind came up until now, this is the only area of science, save the germ theory, that has gone through so many iterations and revisions. And it is absolutely fantastic to see how it has grown and evolved over the years. If we were to talk about the ancient and the modern pain theories, the first three are the ancient pain theories and the other three are modern pain theories, and the story doesn't end there. There are many, many more pain theories that are coming up to date. A quick summary of the pain theories, just out of a sake of interest. Don't switch off yet. The first one is the intensity theory, and it was the Greek philosopher Plato that thought of pain as just an emotion. So that's how it started, the understanding of pain as just an emotion. And then quickly, for a long time thereafter, until 1644, many people thought and attributed pain to divine retribution. They thought it is a punishment of the gods. You might want to call it as the karmic understanding of pain. You do bad things to people, you suffer pain. You can do bad things in this life, or you could have done it in the past life. And that was the mainstay philosophy for a long, long, long time. Until this person named René Descartes came and he said, pain can only be possibly two things. Either it is physical or psychological. And he said there is no way that these two things can overlap. And he strictly saw this as a dualistic presentation, and either or, not a both and. Now, all of those are ancient and redundant theories. Much has happened since then. In the specificity theory by Bell, Mueller, and von Frey in the 1800s, they discovered pathways and receptors and pain modalities, and their understanding of pain actually improved. Then came the very famous gate control theory that I am sure most of you would be familiar with. A sure question in your exams that you can really crack and score about 15 marks back in the day. I don't know how the format is now. So the gate control theory said just the opposite of what René Descartes said. He said it's either physical or psychological, but the gate control theory said it is both mind and matter. It is both mind and body. And Melzack was also involved with developing another model because he felt that there is a lacunae or deficiency in the gate control model. And so he developed in 1990, closer to when we started school, a neuromatrix model where he said pain is not just physical and psychological. Pain is physical, cognitive, and emotional. Now, that's the background, and that the context is very important for us to see how things have moved on from there. Now, towards the time we came to our final year, the biopsychosocial model was a big hit, and everybody was speaking about it, everybody was reading it, and this was an exam question as well. So biological, psychological, and sociological factors in the contribution of pain. But even that seemed very inadequate. How do I go back? Yeah, even that seemed very inadequate. The physical, the psychological, and the social didn't seem to answer all kinds of pain presentations that people would come into the clinic with. And so scientists were constantly trying to see what they were missing. Then came the biopsychological, sociological, and behavioral model. And in behavioral, they said your behaviors and your routines, like your sleep, your diet, your exercise, your substance use, and so on, also mattered. So the theory, which was supposed to be a robust theory, is beginning to expand. Very soon, Mosley and Butler. Mosley is a pain scientist, and Butler is the famous one that taught us the nerve flossing technique, both of them from Australia. And they said there is actually something more, psychosocial, and other factors like not just drug dependence, but also somebody's financial condition can influence pain perception, cultural barriers, the litigations that he might have, the language barriers, and the lack of health insurance in certain parts of the world. So all I'm here to say is the topic that we are looking at today is something that is complex, that has baffled humanity for a very, very long time, and people are still discovering more and more, and perhaps we are just scratching the surface of this very ubiquitous but very fascinating concept called pain. Now, as a physio, I've been very interested in pain. I'm fascinated actually with pain. My friend and junior asked me, why are you so obsessed with this idea of pain? Yes, this idea of pain is very, very obsessive as long as it is not with you. As long as it is your neighbor that is struggling with pain, it is very, very fascinating. All right, so that's the theories, and we are quickly going to move into pain categories. There are three pain categories that I want to leave you with. When we studied in school, there was something called as nociceptive pain. And then, of course, there was the neuropathic pain. You know what it is. Now, since 2016, there is a kind of pain called nociplastic pain. I'm sure some of you might be aware of it. And that's the new shift in trend in pain science and pain medicine. So what is nociceptive pain? Nociceptive pain is a type of pain characterized by heightened or aberrant pain signaling within our CNS, even in the absence of tissue or nerve damage. So there's no nerve damage, there is no tissue damage, but this person is still struggling with real pain. And it would be wrong to tell him that you have all your pain in your head, and I want you to refer you to the psychiatrist. No, there is this category of pain called the nociplastic pain that pain scientists are really advocating for, and it is changing the game of pain practice. So nociplastic pain simplified in your clinical presentation would be difficulty in identifying the cause of pain. It shouldn't come from your clinical shoddiness that you're not able to identify the cause, but you have done all of the tests and nothing is showing up. There's a difficulty in identifying this, and it would be nociplastic. The location and localization of pain is not sharp. The onset is sudden and constant and unremitting. The unresponsiveness of nociplastic pain to all kinds of traditional treatment, and its association with disrupted sleep, fatigue, depression, and anxiety. Now we are moving to the third part, which is the pain structure. And this is where I want to bring in from my years of practice and understanding that my patients have given me. Conventionally, pain structures are extracranial, intracranial, and miscellaneous. So you would typically say extracranial, skin, membranes, blood vessels, muscles, tendons, ligaments, periosteum, bones, joints. Intracranial, the brain itself doesn't appreciate pain, but the meninges and the blood vessels do. And when you look at the miscellaneous pain structures, we have our teeth, eyes, ears, viscera, spinal cord, meninges, and the nerves. Now, that's the conventional reading of pain structures, and there is a lot that has changed ever since. As Ida Rolf said, where you think it is, it ain't. Where you think it is, it ain't. And that seems to be the dictum of any pain practitioner that tries to look and locate pain in our patients. Where you think it is, it ain't. So obviously, all of these are structures that we are going to look at. But after you have examined and ruled out all of these structures, it is still not evident to you where this pain comes from, and you can't quickly write it away as pain in the head or nociplastic pain. There is obviously something that we have been missing, and the last 2 decades have told us beautifully what we are missing. What we have been missing, and what I advocate for in my own pain practice, and perhaps yours from now on, is an important underrated link, an obscure link, a redundant link, and a robust link, and that link is called as the fascia. Now, that is typically the fascia that your anatomy instructor would want to first do away with when they show you the cadaver, because they are so interested in getting it out of the way to show you the muscles deep inside. But I'd like to tell you that is a big disservice to fascia, because the fascia holds a lot of secret to the pain that we all go through and our patients are perhaps going through. So typically, the fascial web has 4 different types or components: the aponeurosis, the epimysial fascia, the visceral fascia, the parietal fascia. You'll be familiar with all of this. But the recent advancement in fascial science is that fascia is not just solid, there is also a fluid fascia that we need to be aware of. And that's what I will speak in a few slides from now. So we have this web. It's like the cotton candy of the human body, fuzzy, woolly, and all throughout our body from head to toe. And that's the fascial web. This is a schematic diagram of the fascial web and the components of the fascia that we'll be familiar with. This is a real-life image, magnified many times, of the fascia. This is again an image of the fascia at a microscopic level. And we are zooming in. This is how the fascia looks within the cross-section of any typical muscle. So you're thinking muscle is a solid thing and around it is an epimysial fascia, but inside there are so many fasciae, and it's important for us to understand literally that the whole body from head to toe is full of these fascial nets, or endless web, as somebody calls it. Now, I think in the 70s, in anatomy, there was this major breakthrough in technique of preserving bodies, and that technique is called as plastination. And this plastination technique is removing all of the water from the human body of cadavers and then injecting it with some dyes and some resins and making it stiff and preserving it for hundreds of years to come. So this model that you're looking at is a cross-section of the mid-thigh with all of the fascial walls, the outer fascia, the superficial fascia, and in what is in view is not the internal deep fascia. This is another image of the plastination studies. And this is a very famous image of the 3 poker men, all plastination models preserved in a museum in Germany called the Plastinarium. And if you observe carefully, 2 of these poker players are exchanging a secret card, through their feet. You're not able to see that because the photo is not very clear. Humor aside, the science of plastination has changed our understanding of pain structures. A quick fascial trivia. What is fascia? Extracellular matrix and connective tissue cells together form the fascia. That's the simplest definition we can have. And how early does the fascia develop in the human embryo? As early as 2 weeks from head to toe. And it's been with us ever since. Where is the fascia absent? It's only absent in open tubes of the digestive, respiratory, and other hollow systems of the human body that are devoid of the fascial net. Everywhere else, every conceivable other part of the human body has fascia. The average body, if it is about 70 kilos in weight, 18 to 23 kilos are contributed by the fascia. That's about 1/3 of an average man's body weight. And that's a lot. And that's what we want to cut away and throw off to look at the muscles that we are supposed to study and learn about. So 18 to 23 kilograms of fascia. And the fascia is constantly responding to stress and strain. You're jumping, you're playing, you're doing all kinds of activity. There is tissue degeneration, and the fascia is constantly repairing and building new tissue. And 40% of muscle force, let's imagine somebody is lifting a 100-kilo weight bell. 40% of the strength that goes into lifting that weight against gravity is contributed by this so-called redundant, useless fascia. Tensile strength of fascia per square inch is 900 kilograms. And that's the reason why our bodies are standing the way they are standing. Otherwise, all our muscles will fall off like jello and slime. So what I'm speaking about is about a very fascinating structure of the human body that we seem to have long neglected. It is one of the richest sensory organs in our body. Hear me out carefully. It's one of the richest sensory organs in our body, embedded in nerve endings and mechanoreceptors, muscle spindles, Ruffini, Pacinian, Golgi, free nerve endings. Everywhere, it is the richest sensory organ in our body again. Fascia also, interestingly, that we may not have studied in our neurology classes, plays a major role in perception of posture and movement, affecting proprioception and coordination. And the typical morning pain that many of our patients or us complain of comes from changes in the viscoelasticity of the fascial system overnight as we rest and recover. So there's a lot about the fascia that we need to know, and this is a picture of the continuity of the fascia from the tongue to the tip of our toes. It's one continuous line. Fascial therapists and fascial specialists will say, are there 600 plus muscles in our body? Or is there one muscle in our body separated by 600 fascial pockets? That's the way they are beginning to look at things. And that's the change in pain treatment and rehab perspective. This is a picture of somebody's leg, and you look at a fascial emergency rooms in UK after having, he's a construction worker, after having jumped on a nail which was 15 centimeters long, which went right through his boot into his foot. And so he was hollering and shouting, and he was rushed into the emergency room. This was published in BMJ in 95. And then immediately some very smart resident, without removing the boot, which is a good thing, immediately ordered for an X-ray. And this is how the X-ray looked. And after looking at the X-ray, they removed the boot very carefully. And when they removed the boot very carefully, they discovered that the 15-centimeter nail had actually gone between the big toe and the second toe and has not even touched his skin. But yet we have this fellow hollering and shouting and jumping off his bed in pain and in agony. And that's when Australia started thinking of this concept of nocebo. You all know of placebo? There is this concept of nocebo. A good example of a classic nocebo is this. It's the opposite of a placebo. Instead of relief from belief that somebody's therapy is working, oftentimes it happens if the patient trusts you. This is grief coming from belief that you have really something going wrong in your body and that you are struggling with it. And that brings us to nociplastic pain. And that's what Australia has been doing. Now, if you look at the rest of the world and you ask me what is a pain approach that we should all adopt to, I think we have no definitive answer. We're all probably still scratching the surface. But the PRISM approach to me seems quite impressive and very comprehensive and robust. It is pain recovery integrative systems model, again by Mosley and Butler. So what are they talking about? They're talking about pain literacy, which is important in pain rehab, pain physiology, pain mindset, pain context. Now, context is a very big word in pain science nowadays. What is the patient's context? Why is he experiencing pain is a question you have to constantly ask yourself. In physical capacity and purpose. So how do we as rehab professionals come in? Now, when we are looking at pain literacy, we need a pain educator, and our occupational therapy friends can be just that. When we need a pain physiologist that needs to understand certain biochemistry of pain and prescribe certain pharmacological solutions to pain, then we have the pill prescriber. I'm not calling that a doctor. Yeah. Then we have pain mindsets. And again, the need for a pain counselor or an occupational therapist who can match up to that comes in. Then we need the person's context, so a pain sociologist. Again, an OT can fill in there. Then we have physical capacity building. A pain physio comes in there. And pain purpose. Depending on their purpose for life at that particular point in time, their idea of pain and their recovery from pain can be influenced. So if somebody has a particular purpose in life, regardless of whichever worldview he comes in, that helps combat pain is the understanding. So we need a pain chaplain or a pain belief officer, whatever you like to call it. So as a pain physio, what do I have in my armory, and what are the big important questions that I need to ask since I am a physio in pain practice myself? Now, gone are the days that we relied heavily on modalities, and the shift is clearly happening towards manual therapy. I'm not saying do away with your machines, but your machines have limited value. There is not much of support for the many therapies that we still continue to use. And so manual therapy seems to be a new player in the game. Again, exercise therapy, my biceps is hurting, my lateral epicondyle is hurting, and so should I just focus on ECRB? Or should I do something else that is more structural and holistic? I'll put my bets on structural integration and not isolated exercise therapy anymore. Do I look at muscles alone? No, I don't look at muscles alone anymore. I look at myofascial trains. And there are at least 13 myofascial trains in the body from head to toe. At least 6 of it converges near the foot. And so the importance of this profession called podiatry. We used to laugh and heckle when podiatrists used to come. And I distinctly remember there was one when we were studying and we said, oh, they're treating only the foot. But then it took me 20 years to realize that a lot of these myofascial trains are winding around the foot. And you get access to at least 6 in that small area. And if you treat one and release tension in one, you find a relief in tension in the low back. Okay, so again, nociceptive pain versus nociplastic pain. Conventional ideas of understanding and evaluating pain versus a contextual understanding of the patient and his immediate familial and other context. So am I only going to be saying no, physio only, and physio is all I will do, and I will not take help from any other professionals or field? No, as rehab professionals, we know the value and the weight of teamwork. So integrative therapies have to be accounted for. And it's not wrong for you to educate yourself in some. So here are some integrative therapies that are in vogue. I'm not going in detail. Manual therapy, of course, is one. It's part of physiotherapy. And then osteopathy. I used to laugh and heckle at osteopathy some time ago, but now I understand there is a lot of science in relation with the fascia and the fluid fascia concepts and the holographic fascia concepts. They were not able to explain earlier why they were checking CSF pulsation. What is this craniosacral therapy? But now the dotted lines seem to be at least connecting in a hazy way for me. Podiatry, a big yes. Dry needling. And what's really whipping up a storm in the Scandinavian countries is a new specialty called napropathy. You will not find many napropathists. Napropathy is a specialty where they are only studying connective tissue disorders. And this is a group of people that use a lot of principles, give and take from physio and osteo and whatnot, but produce a lot of benefit in the area of pain. And of course, dry needling is something that I've had tremendous help with in sorting people's pain. So paradigm shifts are happening, people. Change in trends are happening. There is much for us to catch up on. And as the good book says, and there shall be no more tear and no more pain. And so we, until that point in time, at least in my worldview, I believe I have to be a pain warrior that ups my game and see what I can do to this hurting world. Thank you.
Thank you so much, Charles, sir. And the floor is open for questions. If you have any questions, you can ask.
Yes, please.
Yes,
Let's proceed. How many of the OTs are involved in pain management that you need to tell me? My pitch is that there should be more OTs involved in pain management. And I just saw in the PRISM model some very potential areas where OTs can really contribute. And in reality, I don't know, at least back in the day that I was in pain clinic, there was an OT in pain clinic as well. That's about 15 years ago. I don't know. Huh? There is an OT still in the pain clinic. Great. So there is role, and there is actually more scope and more role. Maybe you can take this and start speaking in your own circles of influence and encourage people and creatively look at how this can be collaborative. And it needs to be collaborative because it's so complex It's so ubiquitous. It's there everywhere. And everybody needs to pitch in to do their bit to help people in pain. Thanks, Chris.
One more.
Yes.
Can you pass the mic here? Yeah.
Sir, as our understanding about pain Jesus, what would be the future of symptomatic treatment? Because most of our OPDs are based on symptomatic treatment. What would be the future of symptomatic treatment?
Yeah, the future of symptomatic treatment seems very, very, I don't know, I need to be politically correct also here, right? The future of symptomatic treatment doesn't look bright to me at all. We should, that's why I started with that first slide from Ida Rolf that says, where there is pain, don't try to look for the symptoms alone. It's not there. It's not there where it is reflecting. It's not there where it's surfacing. You need to really go deep down and look at the root. Opposite my house, there used to be one huge neem tree, and all of a sudden, 1 month ago, it decided to fall. Okay, and then people came to clear it away, and they said this is termite infested. But it was nice and green on the outside, flowering and budding and whatnot, but it was really not healthy at all. And then I understood 2 months ago, we had to call the pest control guy to do some pest control for some termite infestation in our first floor rooms. That guy said, I don't know where this comes from, but it seems to have come from somewhere. And then we understood that it's coming from this neem tree outside our compound that just dropped dead. So symptomatic treatment is disastrous. If you are a real pain physio, real pain clinician, you know that symptomatic treatment cannot get you anywhere much. Yes. Yes, 2-3 hands. We'll take Sundar's last. He might ask a question just to irritate me. You can speak up. We can load up and train fascia. That's called structural integration. Instead of working in specific muscle groups, we need to look at which fascial trains are involved, and we need to try and train them using the science of structural and functional integration. A couple of months ago, there was an 8-year-old boy that came to my clinic. There is a sports center behind my house. It's called DP Sports Center. And this guy, 8-year-old, was a budding tennis guy. So the coach also came along, and he said, first thing, he wakes up in the morning, he calls his mother and asks her to pull the skin on the back. And then he says, Amma, I'm feeling nice. So I examined him. This guy is only this size, okay, just about a head taller than the TT board itself. And the coach told me that on a typical practice day in a summer camp, he had to take 1,000 balls. Okay? Practice. And so when I undressed him and looked at him, I could see that his spiral line, there's a line called the spiral line. You can read more about it in Anatomy Trains by Thomas Myers. His spiral line on the right side, is just crossing the body like that. I wish I had a picture, and it just stands up. So he's been training only one side repetitively 1,000 times a day, an 8-year-old boy. So obviously that fascial line has become tense, it's become tight, there is asymmetry, there is imbalance. And then I told him that we need to reestablish symmetry, We need to train the opposite fascial train. And there was also another lateral line that was involved and an arm line that was involved. So move from treating muscles to treating myofascial trains. Structural integration is what you want to go and study and look up. Thanks. No. I think you lost the first part of the trivia. The first part of the trivia said, for any physical load that the human body is typically overcoming, 40% of that load overcoming comes from the fascia. Fascia need not be a contractile structure, but the fascia is all the time ensheathing and enveloping muscles on the outside and individual muscle fascicles and spindles on the inside. So it's a rigid net. And depending on how turbid it is and how hydrophilic and hydrated it is, it contributes to what is called as tensegrity. It has tensile strength, 900 kilos per square inch. So there's more to explore. It need not be a contractile structure, but it is what is encasing all contractile structures. And the force generation from a fascia is about 40% of any load. Yes, Shiva. Yes, yes. Absolutely. Absolutely. And I have to take it if it comes from Shivram, yeah, PhD in bioengineering, GCU, yeah. Thanks. Thank you.
Thank you, sir, for this fascinating
Yes, Vidya.
talk. It's related to something that I've been studying over the past few years. I'm happy to hear what you've shared. I just have a question. I missed the very beginning. Do you have studies on pain related to labor and birthing? When you say treat the cause and you talk about fascia, the way we are birthed, the way a person, human being comes into the world, the fascia is involved there.
From week
And
2, yeah.
Have you come across studies which relate to the root of pain being from the way a person was birthed?
Yeah, that's a very good question. And now what I'm about to say might sound as pseudoscience to many of you. But when we do fascial release, and I've done this for an optometrist, not about even a month ago, that had severe problems. He's only 29. And when I released his back, he was literally sobbing. Okay, and many fascial therapists will tell you that along with physical release, there is also emotional release. So there's a lot of complexity and overlay. I don't understand the mechanisms. I haven't studied it in detail, but I can, give me 5 minutes, I can pull some research. I'm sure somebody must have done something there. Again, Shivram wants to talk, yeah.
One of the things we learned recently in the last year in the UK is that we're looking at how future of physical curriculums should be. And I led that particular work. And one thing we realized is when we talk to all the stakeholders and we look at all the evidence, that everything we know, at least 95% of things for the human body, anatomy, physiology, all the pain theories, everything was explicitly done on men. So the gender normative differences are there, and we still do not understand anything about how things work with women as such. So I think one of the recommendations which I wrote for UK therapy is to include an understanding of how different it has to be taught in the curriculum exclusively as such. And there are some bits of work which you talk about in terms of pelvic health. Again, if you talk about women's health, everything is narrowed down to pelvic health alone, which is completely wrong. as such. So I think it's a fantastic question. If you want to read up more about how everything is done. So that's why some of the pain medications here in pharmacy, pain medications doesn't work on women as it works on men. From the mind appeals, yes. Okay.
Of fascial release?
Because you don't know what is happening inside, isn't it? I mean, you're doing right from the outside. So how do you actually objectively analyze what you have done to the patient? Because this is all like what you're saying is like trigger release and all that, isn't it? When
Trigger?
myofascial release techniques is that's what probably it is. So how has anybody done, like I remember when I was sitting things colleges for ultrasound, they were actually looking at ultrasound and the changes in the tissue while giving them what is the reason for healing of tissues. I mean, this was many years ago. But I'm just thinking, is there something you have research being done to see what is the effects of this on actually internally?
Yes, ma'am. Lots of research has been done in this field. You just need to go to any body works journal. Now again, body works journal don't have a high impact factor. That's because many people do not know that they exist and many people don't read it and many people don't cite it. Obviously, the impact factor comes down. So that doesn't become the real factor why we are not reading those journals. There is body works journals, there is Curious, and there are fascial research groups. In fact, in 2022 and again in 2026, there is going to be a World Congress of Fascial Therapists that's going to happen in Germany. So a lot of scientific stuff is being done here. And there are ultrasound guided studies also to see what's happening when somebody is doing dry needling, when somebody is doing a triplanar release. And it's only that we are not aware of it in the mainstream. And so we often think it is pseudoscience. I am a clinician. I have a clinic. I'm not attached to an institution, so I don't have the luxuries of research. But definitely when you are doing a triplanar release, you can visibly see, even a bystander can see the change in length of the tissue during that one session. Yeah, how to measure that is not within my resource
I mean,
capacity.
it's like saying, electrotherapy, it's more of a placebo thing.
Mhm.
Like, that's exactly what you just mentioned.
Not all of it.
Not all of it,
Yeah.
but some of it, yeah. So this has
I
been
used to
going
work in electro before. Yeah.
Yeah. Going on through. So I'm saying there should be more of something evidence which will prove that this is it or this is not.
Yeah, so I think that's what perhaps later on Preethy and Abraham will touch a little upon. How do we make the transition from the lectern to the clinician's table or vice versa? Seems to be the dividing point of contention for most of us. Now, unfortunately, the very busy clinicians either don't have the resources or the interest in proving anything to the world, but are only happy about treating their patient and pocketing the money and living a life. Or the researchers are not having enough interest in clinical practice and they're not doing hands-on work. So there seems to be this dichotomy that a forum such as this can actually creatively try and plug, because we have academicians, clinicians, researchers, everybody. I hope at the end of this CME, when the other two researchers finish their talk, we'll see all of this coming together.
Thank you.
Thank you. Okay.
If there are no more questions, we'll move on to the next session. Thank you, sir, for the informative session.
And there are lots of credits that I have given in the last slides, about 13, 14 references, ma'am, of research. All of this is taken from scientific evidence. Thank you.
Thank you, sir. So there's one question there.
Yes. Sundar, sorry. Yeah.
Thank you, sir. We'll move on to the next session. The topic is Beyond the Degree Career Pathways After BPT and BOT. So with a lot of students here, this will be a good topic for you. So please pay attention. The speaker for the session has a vast experience in entrepreneurial skills, training over 8,000 women in community. And she also has started school health champions, and she's been awarded various awards like Ashoka Fellow Award in 2011 and for her contribution in community health. So please join me in welcoming Mrs. Mukteeshwari Bosco, batch of 1983 PT. We welcome you, ma'am.
Hi, good morning. After a lot of pain that we talked about, I'm sure that all of you saw me limping. So I have to go back to Charles for an appointment to release all my myofascial pain and from top to bottom. I'm sorry, I'm the 83 batch, so I need some light. It's great to be back here. I've come, I think, we were the first batches, Veena, Ravi, to have fought for all of you to be sitting here. And that was a time. And we fought so much. And fortunately or unfortunately, I have gone beyond the degree of occupational therapy. It is actually a privilege to return here to this space, one that not only equipped us with skills, but shaped our hearts, our purposes in life, and our posture without pain towards service. It is truly, to me, it is joyful to be here to see so many youngsters, passionate. I met about 8 of the interns as last night, and the passion they carried in their hearts and in their work. And all of them were talking about neurology and rehab. And the one question that I asked them is, how many of you are in community medicine? How many of you are in mental health? Unfortunately, none of them were. But I hope that that passion that we had when Monica Hopkins was our clinical head and pushed us towards a holistic kind of approach to occupational therapy. I still remember walking through all of this. Now you have all these fancy buildings with air conditioning, Wi-Fi. We sat behind MIQ in a small little dungeon place. I don't know if it is still there. And that is, they don't have it here? Oh, so sad. That was such a beautiful dungeony place that we could hide there and do all kinds of things, dream up ideas, not just in our work, but also how to trouble Shanti and Monica Hopkins, and of course, Mr. Paladi and the rest of them. To me, many times when people ask me, who is your icon? I always come back to Ida Scudder. To this day, everybody thinks that she started something with service in her mind. But when she started CMC, when she decided to become a doctor and come back to India and start the Christian Medical College and Hospital, I see her as a revolutionary, not just in service. She had the gumption to go back, come back as a lady doctor, and decide to start training women nurses. That is where it started. And then there came the medical college and women trained as medical professionals, as doctors. And today, of course, we have become the most patriarchal, hierarchical institution that is in the world. She dared to dream differently. And she just did not stop with just starting CMC. She created a movement. And that movement today you would see in the, I think, 900 crores that Azim Premji gave to CMC. And he did not give it to just for training alone. He looked at it to train people to carry forward the movement and the revolution that starts here in the rest of the country. And specifically for that reason, he gave the 900 crores. So what Aunt Ida started as a revolutionary movement, it becomes very, very important for each one of us in whichever area, whether it is pain management, whether it is in CBR, whether it is in rehab, anywhere, to take it forward. And to me, being an occupational therapist trained here, it is just not a degree, it's a crown. Very proudly, anywhere in the world when I go, I say, where did you study? I studied in Christian Medical College and Hospital. Which batch? 83. Oh, you must be a doctor. I said, no, occupational therapist. And that is the time people realize that CMC trains people other than just in medicine. They do train in allied sciences, paramedical, nurses. And this is something we need to carry with pride, with ownership, and dig our heels in. And what Vellore taught me was a tool not just for us to carry as a crown, but to uplift others. Not only the ones who come to us in our clinics, but also in the community, also beyond our hospitals, our clinical rooms, and in the community. And that is what Aunt Ida from day one started. She started in Tiruvannamalai and Dindivanam, and she converted her drawing room into a clinic, and then decided, let me take the Jatka and go into the villages because nobody was coming to her. And that is what we are called to do. The motto she gave us, I don't know how many of you actually, it embeds into your cells. I know for Rabi it is there, but a lot of us, the motto that we carry, how many of us think about it, not to be ministered unto, but to minister? And that's a powerful, powerful motto, a powerful Bible verse. How many of us carry it in our hearts, in our work, and in our personal lives? This is a question that we need to keep asking. And that is what is the truest North Star, not the BOT, not the BPT, not the MOT, not the MPT, not the MBBS, not the DMs. It is the motto of not to be ministered unto, but to minister. And that, if you make it as your North Star, then you start walking towards that. When I graduated in occupational therapy, we were the second batch of degree holders, I think. And I believe my pathway was within the hospital or within rehab centers, working with children, the elderly, mental health. That is what I was called for, I thought. As early as in 1987 and 89, I was thrown into, as an intern, I was thrown into the mental health center. If you remember, there were no staff in mental health center. People were resigning, and Ms. Monica Hopkins said, Mukti, go there. And I started working as a full-time staff, but as an intern. And the last 6 weeks of my internship, I had to go back to Monica Hopkins and fight with her, saying, how come I, as an intern, I'm not getting a chance to work in all the other departments you have put me in. So I got a 2-week rotation in different places. And working at mental health center, at that point in time, I'm not sure if that is still being done. I started a partnership with Worth. I don't even know if that Worth industry is still running in Katpadi. And decided that acutely psychotic and chronic psychotic patients need to go back and integrate into their workspaces. And that means we need to break the stigma. And I had to go back and go there and educate the staff of Worth, convince them that it's okay to get a chronic schizophrenic or a bipolar patient or a person with chronic schizophrenia or bipolar to work with them and for them to understand the eccentricities and the issues, because Worth was for the physically disabled. These people are mentally disabled, and that was quite successful. Some of them got integrated into their earlier work areas. And I remember when I went and spoke to, again, Monica Hopkins, because she was a clinical head, she was not a person who emoted too much. If she was angry or happy, she would turn red. Beyond that, there was not much. And she said, okay, try it. And go talk to your unit head. And Dr. Abraham Verghese was the unit head, and Jacob John was his assistant. And they said, fine, try it. Let's see what happens. And the support that I got from them about this new idea. And that's where I started with breaking the barriers. Breaking barriers of what is defined in the classroom, what is defined in the clinical spaces. You can break those barriers. You can move beyond. And after 2 years, marriage always takes people away from what they want to do. So I went to Bangalore, and Rabi was already working in the Spastic Society. He said, Mukti, come work with us. So I went to Spastic Society Karnataka, and before I left, people knew that I was moving to Bangalore, and I still remember Air Commodore Chaco came to meet me and offered me a job in the corridors of the PMR physiotherapy department. And I said, who are you? I'm not coming in to work right now. I'm taking a break. And of course, when I went to Bangalore, everything else changed. I worked in Spastic Society and the Medical Pastoral Association, which was a halfway home. And then we started the quarter-way home. There, these two places gave us new possibilities because it was not clinician driven. It was, Spastic Society was driven by a special educator, and the Medical Pastoral Association was driven by a social worker. So it just opened up a whole lot of possibilities that we could look beyond the clinic. And that is the time I realized CMC education is not meant to be within the walls, but outside of the walls to innovate, adapt, and serve wherever the need exists. And in 1994, I went to the US, and that was the land of honey and milk and honey and whatever. And that was the time the brain drain concept started. In 1994, I remember, out of 10 of us, 9 of us were going. Rabi, being with the name of Rabindran Tagore, had said that he was not going anywhere, and his parents would have beaten him black and blue if he had gone outside the shores of India. And out of the 10, today, 2 of us are here, 8 of them are there. I'm not going to talk too much about what Rabi has done in life, which I'm sure after this he will. And every day I worked in the neuro rehab in the US. The one thing that kept coming to me is how resourceful our training has been here in CMC Vellore. There, the occupational therapists and physiotherapists for anything were dependent on a catalog. And when I joined, I started picking up all kinds of things, creating impromptu adaptations, and splints with whichever I wanted, because once you order the splint, it takes about a week to come. So do I just leave the patient as they are and not make a splint, which I could have trained with the health insurance, like a sword on your head, limited time, and the whole 1 week will go waste. So I started using a lot of the material that were available. And at that point in time, my interdisciplinary colleagues there were very surprised. 2, 3 things. Where did I learn my English? And the second thing is, where did I learn to make these splints out of nothing? And all my education was completed in India, and I didn't have to go through any bridge courses in the US to start working as a registered occupational therapist. And that was actually kind of defining moment, because it was just not a compliment to me, but it was a mirror holding to me to reflect deeply on the extraordinary value of the education that I'd received in India in CMC. And not just as an academic excellence, but in service. And the one question that kept haunting me is, did I receive this heavily subsidized education to serve a rich country like the US? And it kept haunting me so much that within about 18 months, I said, I've had enough. I'm going back to India. I had no clue what I was going to come back to do. And it was a question that till today, I question myself. What are you doing? Where is your education taking you? Has it pulled you to a personal calling? And that personal calling is exceptionally important to do whatever you do in an excellent manner. And I always believe that our education did not simply prepare us to succeed, but it has prepared us to lead with humility, to serve with compassion, and to carry a legacy forward. Because not just in India, anywhere, when you say you're a CMC graduate, then immediately the expectation that is thrust upon you is huge. Believe me or not. Initially, I didn't feel it that way. The more I start talking about it, the more people ask me. And especially in India, even in the government circles, when you go and you say you're a graduate of CMC, immediately the expectation goes sky high. Not in terms of academic excellence per se, but in the service and the compassion that is expected from you. And after I came back from the US, I dabbled in a lot of things, including starting a counseling center in Bangalore, which is flourishing till today. Went back to Spastic Society, tried to do a whole lot of stuff there. And then the realization came, as a single person and as a clinician, I'm only leading a clinic as such. But my heart was in the health system and what is the change in the health system that we can bring. Because when I talk about health system, it's the governmental health systems and how can we influence the health system to be able to provide care for the most needy of the country. And I felt my education had not prepared me for that. And so in 1998, I went back to college and did my master's in healthcare administration from Administrative Staff College of India. They were offering an MHA program which Johns Hopkins University. I went for the interview. I was the oldest among the students that were being interviewed. And as my usual cocky self, I went and said, I'm not interested. They were offering hospital administration. I said, I'm done with the hospital administration. I'm done with the hospitals. I do not want to enter a hospital. I do not want to enter a clinic. If you are willing to provide me with healthcare management, but not hospital administration, I'm willing to join. And I love to believe that they wanted me so badly. They said, fine, just come in. But with one condition caveat, saying that you have to bring your professors. Throw a challenge at me, even till today, I'm the first one to grab it. And I said, fine, that's easy. I can get the professors. So I got a whole lot of social development from the social development area. A lot of friends I had made, called them and asked them. They said, sure. And then I called Dr. J.P. Mulyal. I said, they had a guy from IRMA, I think, Institute of Rural Management from Anand, Gujarat. He came and taught us epidemiology, and it sucked. It sucked. Epidemiology can be a dry subject. I said, what nonsense he's teaching. Let me get you my professor. I called Dr. JP randomly. He knew my mother. And he said, all right, you're Dorothy's daughter? Sure, I'll come to Hyderabad. And he changed the way that teaching should be done. All of us, by the end of it, were dying to get malaria and the mosquito which bit the malaria, because he made it so beautifully. He's a great storyteller. And that he ended up, today he is my mentor guide. And if I'm going through really downtime, I said, I'm done, I'm finished, I'm retiring, I call JP. And of course, he will tell me a nice little story. And at the end of it, I'll say, all right, now you've changed my mind. And now I need to become that way. And lo and behold, 5 other classmates of mine who joined in the hospital administration shifted gears and jumped into healthcare management. One, of course, I think works in care or somewhere like that, or Gates Foundation in West Bengal. Another one works for me, and a whole lot of others, I guess, have gone to Australia and wherever. That experience at the administrative staff college and the confidence, again, I put it down to Vellore, the confidence that gave me to take up a challenge and take it forward. That experience taught me only one thing, that when we take an initiative to do anything, resources often follow. And when we are rooted in purpose, help will always come. It may not be at that moment, but it always comes in some form or the other. Post my master's, I ventured into the rural India. I found in myself in remote villages, because I just basically went to understand what is it that the poor want. Because as yuppies, we always think we know exactly what the poor want. We know exactly what the disabled want. We know exactly what is the kind of pain relief a person wants. But frankly, we don't know a thing. When I went back to the rural villages, I met this lady who was a widow. At that time, HIV was at its peak. And she was a HIV widow, and she had about 3 or 4 children, and she had to be supporting Nalgonda district. At that time, it was an Andhra forest area, and she was collecting the firewood. And did you know, sitafal, raw sitafal, when that is cooked with rice, it's a great source of calcium. And ration rice at that time would have worms. She wouldn't wash it, because when you wash it, half the rice is gone. So she would cook it as it with sitafal for feeding her children. I still remember I asked her, what is it that you want in healthcare? Would you be willing to? I mean, it was like fresh out of college. You think that you know everything. After your master's, you think that you've studied a whole lot of stuff. And here I'm thinking that micro health insurance is the answer for all of the ills of the healthcare and access to healthcare. So I asked her, are you willing to pay for it? She said, yes, I will pay for it, but on one condition. I will pay what I can afford. That's not much. And I need to be ensured that I will be provided the healthcare that I need, and I am treated with dignity and respect. That has stayed with me till today. when a patient comes to you, dignity and respect, and that start at the time of listening carefully to the patient without judgment. I have long COVID and I have huge pains. I've been around. The first thing they say is fibromyalgia, that's a psychosomatic illness. Go control your stress. So I've stopped going to anybody. I said, all right, this is the pain, so I might as well just go. I might as well learn to live with it. Because, I mean, you've already given me a chop saying that I need to go to a psychiatrist. I've gone to a psychiatrist as well. And they drew a beautiful diagram and saying how I'm permeating all these stresses from outside into my body and I need to integrate all of this. I said, great. But where I'm coming from is listen to the patient with respect, with dignity, and treat the person with dignity. Don't give labels. And that is something this lady, this poor Dalit widow taught me. If I am treated with dignity and respect, I'm willing to pay. And in many of the villages till today, I keep sharing some of the disabled children's pictures with Rabi, and hoping that at some point we would work together to be able to create a community-based rehabilitation in remote areas. And where disability is, they are ashamed of disability. The children are hidden in corners in the houses. And they have no idea what occupational therapist is or what physical therapist is. They know the bone setter. They know the barber who does massages. But they have no clue that there is something called OT or PT or speech therapy. Because all of us, most of us, 95, 97% of us are in the south of India. We don't venture into the rural, tribal, semi-urban areas of the rest of the country. Our world is in the 4 states of the south of India, part of Maharashtra, maybe in Delhi, maybe in some of the cities. And that is how Healing Fields Foundation started. And not from a textbook. I had no clue what I was going to do, but I said something has to be done because each of us are born in this world for a purpose. Yeah, my calling was very strong. And the only thing I had is the experience that I carried from CMC. During my master's, I came and did a residency in Chad and Medical Pastoral Association, of course, the Spastic Society, because we started at that point in time, the Job Development Center and the Early Intervention Centers called, I don't even know what DEC is called today. And, whatever, I can't hear you. See, I'm old and I've got long COVID, I'm deaf. And so we started, that is today's term. That time it was called DEC. Okay, there he goes. He's the master of all that. And so we began working in communities, really remote, because that was the only thing that I was going to do. And when I went and met the chairman, at that time it was National Rural Health Mission. I went to Delhi, I met him. I still remember Mr. Chaturvedi. And I thought that I had just created this huge micro health insurance program, and it was one of a kind, and the world was talking about it. So I was proudly going to go and present it to him. So I went to him and he heard everything. He heard my background and his doors opened because I was from CMC below, IAS officer. And he talked to me and he turned around and said, great program. I think this will be sustainable. But where have you done it? I said Tamil Nadu, Karnataka, little bit in Kerala and Andhra Pradesh. He said that's the United States of America of India. That's what he told me. He's the first chairman of National Rural Health Mission and IAS officer. He says, Mukti ji, jaiye, go to Bihar or UP or Jharkhand. And if you have done it there and you are successful there, you'll be successful across the world. Doing there is like you have done it in USA. Forget it. It has no value. And that again put a worm in my head because I took it as a challenge. I told you, throw a challenge at me, I'm the first one to grab it. So I ventured into Bihar and UP. And today we have trained about 8,000 women in 8,000 villages across India and narrowed down our focus. Yeah, narrowed down our focus to Bihar, UP, and Jharkhand. And again, a Bihar, which is the poorest. There are pockets which are rich. And we chose to be in the poorer areas, that is the Eastern UP, because Western UP is where all the rich farmers who are led by ticket is there. We went into the Eastern UP, Northern Bihar, Western Bihar, and the tribal Bundelkhand regions and the tribal regions of Jharkhand. And what did we do? We made them, trained them into becoming the first contact for any healthcare crisis in the village. Even today, even though we love to believe 100% of the villages are motorable, 100% of the villages have electricity, doesn't have. On paper, of course it has. On paper, all of us are treated equally, but the reality is very different. And so there are no roads. We keep getting stopped by so-called Naxalites. Today, we don't have the Naxalite movement and ask, where are you going? What are you doing? And every time I go, the castes, the casteism, the communalism, and patriarchy and gender inequality has to be seen and experienced to believe that there is something like that. And these women belong to these villages. Most of them are in Gungats. I don't know how many of you know what a Gungat is. A married woman in the north has to cover her face, not the burqa. Burqa is for the Muslims. These are the Hindu women who have to cover their faces in front of the men, elderly men in their family, and cannot even speak. So we picked up these women and put them into a training, a one-year foundational training. The second one is the telehealth training, where they will provide preventive health education. Most of the illnesses that we treat, most of the disabilities, and that is something I learned from Spastic Society at working at the development center and with autistic children. Most of it can be prevented. I'm not saying all of it can be prevented. Most of it can be prevented by just giving nutrition education. If the mother is anemic, she's going to be birthing an anemic child. If a mother is not taking care of herself, not going for ANCs, she is going to be coming up with complications. And so we decided we will prevent, because the poor, even if they had access, cannot afford treatment and can never afford rehab. Can never afford rehab, because rehab needs money. Even if you give your services for free, a disabled child is a full-time care. So we ventured on preventive health education, basic things like nutrition, water, sanitation, all of that I don't have to tell you, and BLS, basic life support training by American Heart Association. So we have about 8,000 women trained in these, and they are the first responder to any health crisis, and also to create access to the government services. Why I'm telling you this story is it's going to lead on to what your education can do. And all through my education, my basic foundation of training in occupational therapy never left. I think all of you here will agree. The principles of occupational therapy and physical therapy is on function and of adaptation and of holistic care. And that is why you had in Charles's pain presentation an OT and a PT and a chaplain and a pharmacology, a complete team. And so that is the holistic care. Just in my case, they found new expressions. So So now coming back to what lies beyond the degree, I'm not going to go into what you can do in pain management, what you can do in rehab, or what you can do in mental health. It is one thing you'll have to learn is what I'm advocating is not to abandon therapy, not to abandon occupational therapy or physical therapy, but it is only expanding your impact. Impact on your patients, impact on your team, interdisciplinary team, and impact on the community. And one thing is what I have learned is both OT and PT, whether we like it or not, are healing professions, are very powerful healing professions. Don't ever take that out. A neurosurgeon can do the surgery, but only you people can get the patient walking, talking, eating, changing clothes. Just a surgery alone is not enough. So what you are studying and doing is powerful because you are the real healers. And your potential, frankly, does not stop in just your clinical, in your PMR department, in your occupational therapy room. It has to go beyond. Remember, for the 2 weeks that we were in rehab, Rabi, I don't know if you remember, with Dr. Patan Katti, we went to the village. That was again an eye-opener. I don't know if you still have those field visits, because from rehab, when the patients were discharged, one of the things is within about 2-3 months, we are supposed to go and visit the patient in their homes, because that time it was all around Kanyambadi block. And that was fascinating, because that is when you actually experience what you have done. Whether your therapy that you have given, whether it was useful to the patient and their families or not. Because you're seeing the patient and their family in their real life situation. And I'm not sure if that still continues. And that was transformative. So what are the different things that you can do as occupational therapists, as practicing occupational therapists and physical therapists, policy influencers, advocating for inclusive design thinking, disability rights, public access, equity, and justice in healthcare. That is one of the most important things. India is not an equitable country. I don't think any country in the world is equitable. There are divisions even in the so-called Western countries. So you can become policy influencers because you're working with the patient as a whole. And public health professionals designing lifespan approaches to prevention from womb to tomb. Because what kind of environment is created in the womb is again in your hands to influence that up to tomb. And so it would be across pediatrics, across mental health, across ortho, neuro, geriatric. You can become entrepreneurs. You can become entrepreneurs developing tele-rehabilitation platforms, affordable and culturally appropriate assistive technologies that fit into the patient's world and lived reality. None of us have the lived experience or lived reality of the patient that comes to us. We just think we know, but we don't know half of what they live. And that is why from rehab, those field visits to the patient's home makes a huge, huge difference. You can be researchers asking the very hard questions. What difference does early intervention makes in underserved communities? How do we scale therapy in low resource settings without losing quality and empathy? And this is something I've been talking to Lenny for quite some time about a paratherapist model for the people that we work with. Educators, not just within universities, but in the heart of the communities, training mothers, caregivers, and frontline workers to support function, dignity, and recovery in everyday life. As policymakers, as public health professionals, as educators, if we can influence the NHM, those days it was called NRHM, today it's called NHM, National Health Mission, to make the ASHA workers who work with pregnant adolescent girls and pregnant women and children, where if we start educating them about childhood disabilities and how to identify early enough a disability and start therapy. Just imagine how powerful that could be for a resource poor country of India, even though we love to call ourselves, we are the 5th largest economy in the world. All that is BS. So we just need to look at what we can do in this area, how we can prevent disability, and possibly with some, we may not be able to prevent disability, but how to make their lives fruitful. Now, everybody is talking about AI. I love AI. I use AI. I used AI to do this speech because it all depends on how you use, and rather than you becoming a slave, master the AI. The cutting technologies is already here. How are we going to use it? AI can help. I'm not sure. I'm sure all of you smart people would have thought and would also have a design and a plan as to how to create rehab plans that adapt in real time based on patient progress, voice and motion based diagnostics. How can you use that? AI can translate therapy in a language. How many of you use the Google Translator and AI to communicate to a patient who is not who does not, or you don't know their language? I see a lot of Bengali patients. I see a lot of Oriya patients when I come into CMC for a lot of other work. Have you ever used an AI to translate what you're telling them into a language that they understand? Have you thought of using AI towards predictive models that can help you identify and prioritize high-risk patients, especially in communities where every visit, even if it's once a month, that counts? I'm sure Rabi is going to be talking about that in terms of community-based rehabilitation. AI need not replace a therapist, but it can be adjunct to the therapist. It's about extending your rehab to the communities with heart, with wisdom, and a commitment to equity, because that is what today's calling is, a commitment to equity and dignity. The future of therapy is not just in our hands, it is in our vision and in our life's calling. And one thing that we love to start all our programs with a prayer, end with a prayer. We have all our prayers in the morning in the department. Do we consider ourselves handmaidens of God? That is something to think. If you consider yourself a handmaiden of God, then becoming catalyst towards community empowerment and change will naturally follow. And the true measure of education that you're receiving here is not what we know, but how we serve. And along the way, who are we lifting up? That is something that you need to be able to focus on. And today we are living in a world where barriers are blurring, teams are blurring. You have a chiro practitioner, you have acupuncture, who may call his acupuncture dry needling, and you have the bone setter, and you have clinicians, doctors who have gone into rehab. Not as medical professionals, but as rehab professionals. So these are blurring, and not just in the clinical field, even outside. Engineers come in and they start creating adaptations, but will they know? And that is where you as occupational therapists and physiotherapists can become design thinkers. Design thinkers working with engineers to create adaptive tools. You can become a tech innovator, developing AI-supported early intervention, prevention, and rehab training and tracking systems. You can become a mental health advocate, bridging, becoming a bridge between mind and body in trauma-informed care, because even pain is a trauma. Social entrepreneur, scaling therapy services to the remotest part of the country. You don't have to live in the remote parts of the country, but you can use technology to be able to scale across the remote parts of the countries. You can become a public health professionals to lead interdisciplinary teams. I know I'm short of time and finishing. Yeah, I'm finishing. Public health professional to lead interdisciplinary teams and influence policy. You people as BPT, MPT, BOT, MOT students, don't box yourselves. Look sideways. Look beyond the boxes that you've created within and explore, ask questions, be curious. And that is something I still try to figure out. Why are we so scared of asking questions? We are comfortable asking clinical questions, but beyond clinical questions, are we comfortable asking other questions that influence or that may change the communities that we are serving in? What can you do with your degree that no one else can do? Who is waiting for your skills but can't reach a clinic? Who is waiting for your skills that cannot reach your clinic? If Ida Scudder also sat and said, let the patients come, I'm going to sit and twiddle my thumbs, I don't think we would be here. Just remember that. How can your CMC education serve not just patients, but communities and systems? Systems is the healthcare systems of the government and the nation. I always tell Dr. JP, or for that matter, I spoke to Vikram Matthew and I told him, I'm not Christian enough for CMC, and for the outside world, I'm not part of the outside world because I don't work in a mission hospital. I don't work within the four walls of a hospital. And so do you have the courage to step out of the box of mission hospitals, clinics, and the churches? Because beyond those are the world, and that is where we are called to serve. Called to serve not just our communal communities. Remember that. Not just, we are less than 2% in this country. As students, begin to look beyond your own departments. Open your eyes to the opportunities that lie in collaboration. If you're part of a team, make yourself heard. Make yourself heard in the team. I don't know if you still have the grand rounds. Make yourself heard in the grand rounds. And think where you can volunteer your skills in this, in the communities that you work. You need to find the time, find the people, find the cause. But just remember to stay curious, stay rooted, stay open to beyond what is in front of you. I know you are expecting a career path which will take you in your own field. I apologize if you're disappointed, but find your calling. Thank you.
Thank you, ma'am.
Please.
Thank you, ma'am. That was a thought-provoking speech. And as we're running short of time, we'll reserve questions for the last. And thank you, ma'am, once again. And for the announcements, those who have ordered the T-shirts, it's available in the counter outside. And snacks are provided in the foyer. And people who ordered for vegetarian, which snacks are available. Thank you. We'll break now and we'll come back by 11:15. Just a 15 minutes break and we'll come back. Thank you.
want to order a t-shirt now, they can do it outside. Alumni and students.
Third session will be community-based rehabilitation in India, the new context, models, and challenges and opportunities. The speaker for this session is, he served in many organizations, and before starting a organization in Coimbatore for the village women, we would like to welcome Mr. Rabindran Isaac, batch of 83 OT, to present this session. So the dice is yours. Can we maintain silence? We are starting the session.
Good morning, and I would like to thank the organizers for inviting me to come and give a talk. In CMC, I always used to be in the last bench. I have never been behind a podium, so I'm feeling a little like a fish out of water. Anyway, the topic they've asked me to speak on is community-based rehabilitation. There also I have an issue. When I was a student here, even though we know community health was one of the oldest in the country, was started by CMC. And CHAD, as you all know, is one of the leading community development programs. I was never posted in it. Whenever I asked also, they put me in mental health. But anyway, that was what Shanti, who was the head of the department, thought about me going off to Nimhans in Bangalore. But Titu's there, Nimhans. Anyway, now coming back to this, I would like to talk a little more about what is happening. And there I stand. What is this? How do I? Oh. Okay. Community-based rehab is a strategy within community development. So we who all say CBR, remember you're just part of a huge thing called community development. And unfortunately, when I started working in Bangalore in the early 1900s, you go to any NGO, whether they're working with disabled or with anybody, they'll have a CBR board over there. Because that was the one which used to get a lot of funds. Those days, I don't think it happens now, but this is what was, it was more of a fad than anything. Anyway, what, one time. How do I move? Next slide. Okay. So this community-based rehab, people taking care of themselves was thought about in the 1960s, which with the Mukti's experience, etc., it's still happening. You know, there's not much of professional input by we professionals. It is more the villagers themselves. They are all street smart. They decide what to do with the person with disability. And many of the solutions are far better than what we think. So that is what is happening. So that is the real CBR we can talk about, where it is taken over by the community, the parents, the siblings, the caregivers, etc. And they help the person to grow. You know, for example, I mean, this is not a very good example, but many of the Down syndrome children would be in circuses. They would entertain us. They were given a job. They were given 3 times food, etc. But if they come to any of our institutions, they just stay there till about 15, 16, and then we don't know what to do with them. Then we send them back to their homes. So this type of rehab, which is not right, according to, it's according to everybody, was happening. And other things like, if those who have seen Dr. David Werner's book, using crutches with sticks, etc., was used long ago. We got this guy from a village, very smart fellow, a guy with cerebral palsy, who had learned to walk with one stick. Okay, one, like a danda, it was one solid stick. And he used to hold that and he used to walk all over. He used to travel by bus. He used to do everything. Then we thought he should get a decent job. So we made him join Leela Palace in one of their things. And you know what they said? If you walk with that stick, you can't enter from the front gate. You have to come through the back gate. And even then, we learn to walk with crutches. And this guy could not do it. He didn't get the job in Leela. So this is what is happening. Rehab, which was traditional, is not being accepted by the communities. Okay, so this is something in the 60s. Long before that it was happening. And but we have just given up many of those ideas because of our thing saying, or we have this block to say, no, we can't accept it, that is functional. As Mukti mentioned, our jobs, OTs and PTs, is to make a person functional. So he was functional. He was traveling by bus. What more function? I can't travel. I can't climb up those steps nowadays. But see, that was more functional. And we had to throw it away because of our things, technology as we call it. Technology is useful. 90%, but this 10% we should not forget. CBR is a thing, what you call is community in CBR. A very important aspect is the community members should welcome this concept. Unfortunately, with all this education, awareness, saying that many of these patients are brought to cities because of the fact that hospitals are big, they have all the facilities, they know what to do, etc. So the members themselves, the community themselves don't accept us when we enter a community and say, let's do a CBR program. So it starts with we have to make them understand and willing. And then this about the funding part of it. CBR, as you know, it's actually governed by funding organization. You and me are nobody in it. We have to just fall to what the funder tells us to. So the thing is, by what WHO told us was that there has to be mobility the resources have to be mobilized from the community. In my experience, yes, we will have to get some money. I remember when we were here as students, these MCR shoes were given to persons with Hansen's disease. They had to pay 50 paisa or 1 rupee or some small amount so that they value the slippers. If not, they'll come back barefoot once more saying rats ate it up or something like that. So we had to charge them. So this concept is important. When you work in a community, most of the funding organizations would say, why should the community pay? We will give the money. But we have to be careful about that we don't fall for the funder and then take their money, and then your whole program is going to be upset because they'll become 100% dependent on you. The concept has been tried by many CBRs. In the 1995, 96, I think, DFID, or then it was ODA, Overseas Development Authorities, did a study on CBR, urban CBR in India. And they found it was a total failure. All of us on our records, I mean, I was in charge of it in Spastic Society, and I would say on records, we go to so many villages, so many slums, and this is the number of persons we are seeing. Numbers are always there, but what happens to the person with disability is not there. We can give one or two, we would have put about 1,000 beneficiaries, and we'll say two people, one did his 10th standard and one is having a shop or something like that, are success stories. So that was what was happening, and ODA did an intensive studies to say that something is wrong with it. And then I was part of this discussion. And then when we came to it, we said, see, Mukti was trying to tell that we need to train local people. I told her over the coffee, I'm going to be a little controversial with you. Yes, we have to train the local people. But with my experience, I think professionals have to be part of this core team. Okay, I mean, core team in the sense who will also visit the field. The other CBR programs where I have evaluated, etc., there will be a training program. WHS says it's a 6-month training program. 6 months you train the person, then that person will go what they call as TOT, teacher training. You train the teachers, okay, and then they would go and they would train the CBR workers. So there's too much of dilution, especially when specialized fields like ours. We take 4.5 years to complete a bachelor's degree, and there you would have taught them in about 4 days. So this is the problem with the funder saying that this is the maximum amount of money you can spend. And another problem which it didn't happen in Spastic Society is because professionals, we went to the field. We had a team where they would go to the field weekly once. It would work out very expensive. It might even work out more expensive than an institutional based rehab program. But the point is you're giving service to the proper service to the people. So, and also another problem with that is the number of people you can cover. So I feel this Optaa, I give a suggestion that we should take it up to the government to say that professionals have to be in the field, meaning it should be government should pay for this. Okay, they'll say, yeah, you go. That's not an issue. But the point is they should pay the same salary our therapists get working in an institution. So that one is proper service will reach the people. Secondly, all of us will have jobs. You know, that's the thing, that more and more OTs and PTs will have jobs as OTs and PTs. So I think that is something which we need to bring out a resolution or something and then meet the government to do something about it. So this is something which I was thinking of while doing this paper. Okay, I'll just give a little history. In 1974, WHO sent a group of people to India, and I mean, not India, to the developing countries to find out what is happening to the persons with disability in the community. The rehab services are practically non-existent or grossly inadequate in developing countries. There is an apparent lack of national planning. I think we have to approach the Planning Commission for this. There is a thing, planning and coordination of services, medical, educational, vocational, and social, etc. But this was in 74. There has been a lot of development. Like, for example, we have the PD Act and then later the National Trust Act, etc. Maybe we should approach them to try to do something for our disabled. Medical rehab services have usually concentrated on institutional care and with a low turnover of patients and high unit cost. I mean, that is not I don't have to explain that. Mukti was talking about United States of South India also. When advanced rehab services and technologies have been introduced and developing countries, the result has often been discouraging or a complete failure. I'll give myself as an example over here where I use some technology in the thing. It's not very high level technology. It was a corner chair. Okay. I work with cerebral palsy most probably. And those days we used to have a chair where you make the child sit in a corner, strap him up or her. That is not good, but we were using that. And what I had done is I had left it in one of the slums where I was working in and demonstrated with the parent, blah, 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 and all. And I hadn't gone there for some time. And it so happened one orthopedic doctor from US had come over. And a team member of mine took him around to all the places where he worked. So as soon as he came back, he said, who's that guy who left that piece of wood in that village and come? I mean, the slum and come. So I said, sir, it was me. He put his arm around me and said, I think you should read up a little more. Okay, so this is the thing. So that's a simple technology, but it is not being used properly. So one of the mistakes we do is using technology. Whereas a friend of mine now who's in WHO, he actually developed prostheses for villagers who work in the fields. Because the other prostheses which we make, now there is a lot of advanced ones which are very, very expensive. But he made with bamboo and things like that, so that they can work in the field and the prosthesis won't work. So that type of thing, I think Mukti also mentioned that we need to think. We recently found, Mukti and me were classmates, to tell you one thing. And we formed a class WhatsApp group. And you know what we call it? OT is out of the box. Okay, so as professionals, please look what is outside the box. Plan your plan according to what all of us are very good what we know. CMC is one of the best colleges to train us, but we have to learn to look beyond the box. And so that is something which, if we do in assistive devices and technology, see, the minute we say assistive devices and assistive technology, we always look at the high-end ones. And definitely these never reach the community. We have to think of something which is to the community. Another example, one English rehab person, he came and developed a wheelchair. He made a wheelchair for a kid in the slum. Okay, first when he went, the roads were mud roads. By the time he made it, they had tarred the roads. And the roads will be sloped this way, so the water flows up. And this wheelchair, this poor girl couldn't control it. It was so good. I mean, the bearings were good, everything was good. So it kept rolling off the road. So we have to think that it's better to use a poor quality Alamco wheelchair in the community than a good one. Pardon? Okay, so this is the thing. So we need to think about it. And as OTs, both of us are OTs, and she was doing something in America. I can't keep my fingers quiet. I keep doing all sorts of funny gadgets to me, all very, very customized. Very customized you have to do, looking at the patient point of view, whether they're rich or poor or what it is. And it should be aesthetically accepted by the community. I did one spoon, which was so long. I needed the counterweight to get the spoon up. And what was happening is, because of the weight, it was keeping on coming, by the weight, it will come up and the child takes it in the mouth and puts it down. But it was huge. It was about 2 feet long. And none of the patients I made it for used it. So we have to think beyond that thing. See, they mention also that it has been a complete failure. Another area which we don't talk about at all is education. All of us know about Sarva Shiksha Abhiyan. Anyway, do you know what it is? Sarva Shiksha Abhiyan. This girl will know. Veena will know. Anyway, Sarva Shiksha Abhiyan is a government order which said education for all. Okay, that was supposed to be done by 2010. So 1990, they passed this bill, and by 2000, it was supposed to be completed. Education for all. That means all disabled people have to have some form of education. All disabled people have to be taken into schools. Okay, and naturally, 2000, nothing really happened. So then they extended the date to 2010, and still it's the same, because who has to do this work? It's those school teachers. School teachers, as you know, are already overworked, especially the government school teachers. So with that, they have to even look after children with disability, and those who are very severe, they have to do home visits also, and no increase in income. So it was a total failure. So, and if at all they do education also, they have to, there's not appropriate education is not there. So all our disabled children will be sitting in classrooms as a number. In the mid-90s, that conventional system does not work. They found that conventional system did not work. And so rehabilitation in the developing regions needed a number of substantial changes. That's how this PD Act and all these things came up, because they realized that nothing was working in the service delivery system, so that eventually all people with disabilities could be provided at least the essential service and opportunities. See, this is another sentence I put in red because that's not fair. I mean, people who can go to a rehab center or a clinic or wherever it is gets the best of services. But those who cannot do that, the least minimal, if you do, it's enough. It'll end up like that. If you give this to the government, that's all they say. Anyway, we are doing it. We are taking a survey. You know, so that's how it becomes. So it is, I don't believe that in thing. Of the management systems, including policy making, persons with disabilities, their families, and the communities should be involved in it. Unfortunately, I remember when I first wrote my CBR project, I sat in my office and then did some reference here and there and all, and I wrote a project. Okay, and then we got the fund also. But when you actually went to implement the project, it didn't work. You know, because I never got those persons, the people, the stakeholders to be in the planning, which is another area which we need to look at. Okay, this education for all and health for all started in the WHO. Health for all, to an extent, is reaching out to the maximum, thanks to organizations like Healing Fields and all, who are supporting them and helping them. So areas where it is not reachable, there are a few NGOs who are supporting our government health system, and it is reaching out. But one thing I am proud to be from Tamil Nadu, because in Tamil Nadu, maximum community, the people are being reached through their health system. It is one of the best in the country. And so that is there, but there we miss out rehabilitation. In this projects, rehab is not there anywhere. And so the old method of people who know how to handle the child is handling the child. So that is the thing. So we need to do more of it. And rehab means us. So I think we need to work on it. I give a suggestion. Our chief minister seems to be able to do things. Unfortunately, elections are coming up. Hope he wins next time also. So because if we can approach him for this, I'm sure there will be support. You all might know that in the Tamil Nadu government, now there's a law that in all what you call government offices like councillors, panchayat president, etc. Persons on wheelchair can apply for that post. All these days it wasn't allowed. Now they have passed a law, our state parliament, to allow these people to do it. And so we will have persons with disability who will be advocates in future in the government itself. So that is something which is a recent one. That's why I thought about this also can be put to our government. See, there is a policy everywhere. You know how the governments work. There are policy are made, but implementation is where the problem is. That is why I spoke about Tamil Nadu, because I've seen implementation. I was in Karnataka for a long time, working in the rural areas, where I found that implementation of the PHCs, there won't be a doctor over there, a compounder will be sitting, those sort of things. But in Tamil Nadu, you do some blind visits, you will find some doctor available. So that is my experience. I mean, it's a very, very subjective experience, but that is happening. So that's why I'm saying it is everywhere. It is in the national policy. These things are there, but implementation is missing. Usually there's a funds problem. We don't get the money. The state doesn't get money. How will it do this? Another thing was our budget. It is found that 90% of whatever is kept for health and maybe in brackets rehabilitation, 90% goes into the urban areas. Only 10% goes into the rural area. And then interestingly, only 10% are in the urban area, the disabled, and 90% are in the rural areas. So that is an area which is great. See, CBR as such is a beautiful program. What I'm trying to tell you is, if we talk about CBR, everybody will say, I mean, they won't bother about it. It's because of this. I mean, if it was properly managed and planned, etc., I mean, CBR is an answer. So we'll come to that. I want you people to say a few things. See, the actual technology is down to top. Okay, but in all our planning, it is top to bottom. Okay, so we need to go to the grassroots, find out what they want, and then do it. Like Mukti was giving an example where this old woman told her her story. And so after that, you could build on whatever the community wants. But unfortunately, it's not like that. It's top to bottom in most of our projects, even today. And so that is where the problem. I'm talking to you, all this is because I started working in 87. And 87, I was dumped into CBR, outreach. We used to call it outreach program. And as I told you, I didn't have any experience in CMC. So I didn't know what I was doing. So I went into it. And then, so we planned something those days and then realized it doesn't work. It took us almost 15 years before our first proper CBR project was written. So that is what happened. So we need to go from down to top. There's been a lot of failures before I'm confidently telling I can do a CBR today. Okay. So this is the same question. Does rehab happen in the unreached places? The answer is yes. As I mentioned earlier, maybe things are wrong. Things will be done wrong. For example, we used to, when we were students, we used to see a lot of these Walkman's ischemic contractures. Then later it was caused by the Puttur doctor. I think in our time no, Puttur is there, but they do good jobs also. I mean, I'm not against Puttur doctors, but certain things which they do can cause a disability, like a workman's ischemic contracture. So that is still going on. And actually, when we went on our orientation program, I had a back pain and somebody suggested, why don't you go to this Puttur fellow? I said, no way, I'll have every other pain possible. So I'll go to the physio later. So that is the thing. So they are doing good jobs when more ordinary fracture. If it is compound or anything complex, please don't go to Puttur doctor. If it is just a hairline fracture with it heal by itself, you go to a Puttur doctor. So that is the thing. So this type of treatments are there. Then there is always this other forms of medicines which cures. Like this patient who was severely disabled. I mean, no eye contact. And she was about 2 or 3 years old and severe mental retardation wasn't able to move at all. Okay. And this child, the parent was giving homeopathy treatment. So I asked, how is homeopathy helpful? Then he said, see, when I go to an allopath, each one tells one different thing. One fellow says in 6 months she will become okay. One fellow says you take this medicine, she'll become okay. Some people say, no, it won't. She won't become okay. Okay. But wherever he went to a homeopath, they all gave the same answer, saying the child will improve. So that is the thing. So those things are happening. And only if we people intrude into these areas, maybe there could be a change. But till then, even then, I'm talking about what happened in Bangalore city. Okay, so in a place like that, if it can happen definitely in a rural area. Okay, then at that time in WHL, they spoke about how can it reach to everybody. There was a big discussion. And that is where they did that My Time CBR program where they used to have this 3-day training program for the teachers, the trainers, and then these would follow up over there. And I've evaluated some of the programs. I don't want to mention the names. Because they had asked me to evaluate these programs, and I found that no rehab was happening at all. It was all the other facilities were getting it. Like, for example, the ID card, and you get a pension also through the government. Some of the good programs used to get that at least for them. And then the usual thing, though, my time was these boxes, just tin box shops, where one NGO donate this, and then ultimately the person with disability will be lying down inside the house, and the shop will be looked after by a kid who's not going to school. So these sort of things are happening quite a lot. I remember once we went to a house, and then there was this goat tied outside over there. And this CBR worker said, sir, you know what that is? So I said, yeah, it's a goat. He said, no, that's the income generation activity. And then I said, where's the patient? Patient is a quadriplegic guy lying inside the thing. So somebody has donated that goat as an income generation. Okay, it helps the family. I'm not saying no. But using the name of the person with disability doing this is not very right. And so then they said, training is costly. See, now you all do a 4.5-year-old course. Okay. And then after 4.5 years, you will expect equal amount of salary also. So then if you are asked to go to rural areas and work for pittance, there's a concept in those days in CBR was that after a period, the NGO has to withdraw. And if the NGO withdraws, the program has to be continued by the community. So you don't pay the CBR worker more now, because after some time the community has to pay and they can't afford to pay that amount. So ultimately the project will close down. So it was very sad, they were paid some 600, 700 rupees a month. Even a maid servant who works for 2 hours or 3 hours used to work much more than, I'm talking about urban slums. So the women used to come out of the slum to work in homes. So we had a lot of attrition with CBR workers. So that was a problem.
So sorry, sir. Sorry, sir. 5 minutes.
Yeah. Okay. For the situation of the European countries, it would rather recommend. So they spoke about multi-purpose things, which I am saying is not very good. Is there future in CBR? So the recommendations which I'm giving, as I said, I believe in CBR. I was actually one of the doctors named me CBR is community-based Rabi. Okay, so it's so much close to my heart, but now to see it not functioning, I feel little sad. So I think it is a good program. And if we are able to convince funders, that is mainly the government, we'll be able to do a wonderful work and reach out to the maximum people. Okay, now I have this 5 minutes. How much time you have? I have
5 minutes.
start our question, please will combine it. No. Okay. See, I want to know how many of you are working, have you been to our community health programs? How many of you have been posted in community development program in Chad? Not too many. Did you have a community orientation program? Yeah, so you work with Chad. Okay, good. So now I want you to tell me, with whatever I've said and what you've observed, what are strengths of CBR? Can you tell me some of the strengths of CBR? Usually question tends that way, but you know, I'm an out of the box thinker. So I will ask you questions. Can you suggest some of the strengths of CBR? What is the main strength? Why did WHO, etc., think about CBR? I told you the problem. 90% of our people are not getting any rehabilitation. So they thought of this as a solution, for which I gave a lot of weaknesses. But do you think by doing a proper CBR, will we be able to reach more people? So that is the strength of CBR. If we continue with our institutional based work, who will reach to these people? And I also said 90% of them in the faraway places. Okay. So CBR, is it a strength or a weakness? As CBR per se, if you do a proper CBR, is it a strength? Yeah. So that is, you can reach more people. I want, right? Take time. Okay, so it will reach more people. Anything else? Exactly. If you see one thing, if there's an ownership of any program, it will sustain. If you feel you are doing it for yourself and things like that. I think he told me I started a small income generation for some women in a village. See, they own that place. They take the decisions, they do everything. It was dying. I went and told them, let's close it. They said, no, we will revive it. It is their ownership. It is their program. So if a CBR program is there, they'll do it. Then, any other? Yeah, because it is part of community development. It is a strategy. It's okay. One person will keep the discussion going on. Okay. So the thing is, the community will grow. The community will develop. So these people were totally ignored. Some of my best friends are like managers, vice presidents. I'm talking about the person with disabilities, vice presidents, etc., in corporates, etc. So the thing is, they're doing service to us. You know, they're helping us to grow. I mean, you and me, by being in JP Morgan, Chase, or one. Yeah. No. They are working there. My friend is a vice president of JP Morgan. He's a guy with several policies. So by bringing them up, okay, by CBR, you are going to help the country grow, right? Yeah. Anything else? Nothing more, no strength. Huh? Any weaknesses? Resources is the main thing. Who has the resources? Pardon? No, who has the huh? They don't pay their bills, but they don't want to go to the bank. If they pay their bills, then it's going to be. I think I paid my job to find the same because I got a raise as me. I got more money, like, yes, if I prefer to work. So, I don't. Yeah, it's like, can you tell me what are the threats by doing a CBR? See, the thing is, she's worried that more patients won't come to her rehab center, which is urban center. They'll all be rehabilitated over there. So this is one of the threats which the people are thinking. But to be truthful, there is enough and more patients. So whether you are urban or rural, you will have enough patients. Okay, so, but that is a threat. Yeah. 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 See, now what she is trying to tell is it's in the present date. There are two kinds of people who work into the work in the community. Some are doing it because they get funds. Some are doing it because they want to serve. I want some question from the students, please.
Just to keep us on time, let me take just one more question.
Yeah.
And thank you for the thought. We have one more question from the students, please. Mike. Very good, student, come here.
It's okay. It's okay. At least one question. Why don't you come here?
Check. Hello, sir. So I've worked in little bit parts of Mumbai, Dehradun, and Bangalore many years in here. I find the place where I'm staying presently is in northern part of Karnataka, where the happiness quotient is extremely too high. I feel like it's the highest in the world because you are given a own house. There's a good drinking water provided just before your house. The women are given pension. This, if you know the taluk officer, you get a assembly pension as well as extra pension too. And then the free electricity. And even in Anganwadi, you get all the nutritional supplies. Why should I be rehabilitated? Because I work in both medical, educational, residential for the disabled. I'm finding difficult to motivate them. I have the
Yeah.
funds. I have the IBR setup. I do have wonderful CBR setup. I have everything. But when the differently able is not motivated because the government
It's giving everything.
is giving everything in northern part of Karnataka. Like
Okay.
it is just slightly different in Tamil Nadu where I work with Chad and everything here. The knowledge that I took from Velo, when I tried applying it, nothing worked because they are really satisfied. And even the people there, they're happy with the two jola roti that they eat and the vegetables they eat. They're satisfied. They don't want biryani. You understood?
Okay.
So that is the satisfaction with which they are working. You have any mantras or any strategies how to motivate people who are already really satisfied?
This is when you're talking, this is about differently able you are saying, but it's the same with a normal person also in Tamil Nadu, especially during election. They give money and they don't want to vote. I mean, it's everywhere. It's
No, but that's not his question. Let's answer his question. Has anyone else has a comment? If not, I'll tell, that's why. See, one thing which, there's a thing called a self-esteem. Okay. I remember long ago in Spastic Society, we started a sheltered work unit. And so they will make paper bags and those sort of things is what we were making. And each one was given 150 rupees a month as a income. You should have seen the happiness they had because they worked and they got it. Okay, 150 rupees, you know, has hardly any value. Okay, so that is something which many persons with disability and even women, etc., they might be getting freebies. But at the same time, if they work in Tamil Nadu, I'm talking about women. In my factory, there are women from very low income strata who work over there. Our factory was totally in the dumps. I said, let's close it. They said, no, we want to come and go. They're not getting enough income also. But they're saying they feel a pride that they're going to work and coming back. So that dignity, yeah. Hmm.
On that note, let's conclude. Mr. Rabindran, let's all go. Big hand. Thank you very much.
Thank you, sir. We'll quickly move on to the next session. It's on community-based inclusive development, and the speaker is the founder of PACT, an organization pioneering in inclusive child-centric rehab models. He, along with his wife, is running a good setup in Bangalore. Let's all put our hands together to welcome Mr. Reuban Daniel at the 2001 PT.
So let him change.
Okay. So, good afternoon, everyone. I'm thankful to the organizing committee and also my fellow friends, whoever are here. And I just wanted to just start with something that I had in mind. The session was called a CME, Continuing Medical Education. The Google says like this: these activities help medical professionals stay updated with new research, clinical guidelines, and advancements in the medical field. But I don't know whatever I'm going to speak, whether it will add anything towards this research, clinical guidelines, or whatever it could be. As much as I talk, I think I'll be talking my heart out. Please hear. If you find it's really good or if it's really helpful for you, take it. Otherwise, you can just crush it in the dustbin, throw it along. Okay, I'm just giving you a disclaimer. Right. So what I want to say here is all about the community-based inclusive development. It is the same thing what Mukti ma'am was talking or Rabindran sir was talking. It is just a new, kind of a strategy that is evolving, which is, very useful for countries like India, because it prioritizes rehabilitation over inclusion. So that's what it is all about. So we will be talking and covering a little bit about the context, why it is, from CBR to CBID. That is something that we will cover, and why it matters to India, right? And what is the future vision for CBID? And we will also see some of the case studies which you will try to understand why this CBID is very important in countries like India. So I want to just talk about this CART and its evaluation. So I just have a person who is a farmer in the outskirts of Bangalore. He used to own in the recent times a Swaraj Mazda, truck. And this guy was a farmer, and he used to take this govas, which he is growing in his farm, and he used to go and sell it. And over the last few months, I just saw this guy again switched over to cart. I just asked why. He simply said, I just got the Swaraj Mazda earlier because it made my transportation quicker. But now because of the traffic, I'm only losing a lot of time. So, as much as I'm going in the cart, the same time is also consumed when I'm going in the Swaraj Mazda diesel vehicle. So this is this is in Bangalore, right? So I just want to say this is where CBR is also now coming back, right? So we all started with something to do where we wanted to do something for the people. But unfortunately, because of the leakages that were happening in the government systems, and there were certain things which were happening, which was not favoring the actual people whom it should go and reach. And that's where, the CBID started getting recognized for inclusion over the rehabilitation. So it emphasizes more on rights and the participatory development. And also it has limited focus on charity these days. And Rabindran sir was telling that these days, the donors are not driving the CBR. Now it is the people who drive the CBR. So it is no more a charity. It is all about what they want. That's what is being given now. And they choose what they want, right? So that is the shift that has happened in CBR in these days. And after, the conventions of rights for people with disability and SDGs have come, it has become more localized, and also it has become more inclusive. I have just talked about the cart. Again, I'll just show you another cart sometime later to just see correlate how we have changed in the recent times. I want to just contrast the methodology between CBR and CBID. Whereas CBR was WHO model, which is a medical model which was led by medical model. And it was focusing more on rehabilitation, and the roles of people with disabilities were beneficiaries. So always, if you see, they will ask any organization whom they go, how many beneficiaries did you touch? That's what they will ask, right? With the money that I gave, how many beneficiaries did you touch, right? And the goals were always all about the service access. Like if I just try to make this service, how many people are accessing this service? That's what they were worried about. And it never went to a point where monitoring and evaluations were happening and finding what happened to the people who availed those services. But now the community-based inclusive development starts to think that their rights have to be given the first priority and their dignity have to be given the first priority, right? And what also have happened is, the shift has happened is, now the people with disabilities are no more called the beneficiaries, they are called the change makers. So they decide what they want, right? So that's a shift that has happened. And the goal is, the ownership has emerged. And the goal is also the holistic inclusion in the society. So this is the vast difference that has happened in the CBR and the CBI. So I'm just going to rush through again the same things what Sir has been talking, but in a different way. So since CBR's inception from 70s to 90s, so many things have changed. As I told you, in earlier days, we had very, very limited legal shifts that were happening, which really prioritize the people per se, right? Whenever, like there are some, let us just try to take about in the earlier times, which talked about certain health policies that were coming up, right? So it was never people-oriented. It will only be oriented towards the government, what they need to do, right? And the best example could be the family planning, right? They basically wanted to control the number of people, right? So this actually was something that we have to think, and now it is not like that. The policy changes that are happening, it actually allows the people, whoever are the beneficiaries or the change makers, to take a call and they will try to implement themselves. That's the shift that has happened. And in earlier days, from 70s to 90s, the NGO sector, the so-called non-governmental organizations, which are the ones that delivers the rehabilitation programs, were all kind of, like they had a lot of able-bodied people, not even the disabled people, they were all the able-bodied people who were running that NGOs. So they had a major call on what to do, right? And again, the education was the least prioritized. That was again touch-based, like they said, Sarva Shiksha Abhiyan, right? So it was announced, but still, like how many disabled children are getting benefited out of it, right? So these were all not focused in the earlier times. And economic liberalization was shrinking because they were giving a lot of free buys to the, like people with disabilities. For simple example, Alimco, which was started in earlier days, still keeps giving the free buys, right? So the people with disabilities, I have seen with my own eyes, they will get in one camp, one AFOs, and again, they'll go to another camp and get another AFO and sell it for half the rate, right? So this keeps happening, right? So that's where, like now again, like in the 90s to 2Ks, what happened is WHO started promoting CBR as a strategy rather than a program. So what they started doing was, they started focusing on equalization, poverty reduction, rehabilitation, and social inclusion. But what is the major shift that happened during this time was that they became a primary driver rather than, like they were initially the drivers, like they'll say, I will tell this program, you implement it. I will be sending you this much of money, you implement this program. But rather later they found out that they can try to identify the local partners and they can facilitate the programs through them. And that became very, very effective in terms of delivering the programs, right? So that was a key shift that happened in 2000s. And later, CBR Matrix was published, and where, like they were talking about health, education, livelihood, social empowerment, and also the social inclusion, right? But though they have told, they were predominantly having a lot of challenges because most of the programs were urban-based. Whichever programs that they introduced, they were all urban-based. And in countries like India, they had very, very limited legal framework because, as you all know, in 2016 only we got the Rights for People with Disability Act. right, which is talking about what the disabilities can be included in. So until then, they had a lot of challenges to understand who a disabled person is, right? If they go to a government department, they were only given jobs like chaprasis, they were given jobs like sweepers, right? Where they will not be even able to do because of their, inability, they will be again thrown out of the job because showing that, they are not able to do this job, whichever that has been given. So this also led to social exclusion, and it kept on persisting. And there were very limited awareness on the disabled people. So CBID emerged as a response for this. What happened was there were a lot of disability people organizations that started emerging, right? So NGOs are still NGOs, but we also have something called DPOs, which is called Disability People Organizations, which are run by people with disability, and they started becoming the change makers. So they started pushing what they want. They started saying that we are the catalyst and we will do what we want, right? So this is something that has emerged, and they started becoming the change in the system. They started to become the change in the communities, and they started to become the change to improve the communities, whatever they want to build as such. So why is it matter? CBID and CBR both are the same, but why is it mattering to a country like India? So in 2017, I still remember, I think it was 2016 or 2017, we were taking a questionnaire to understand the participatory scale of people whoever are traveling in the bus. So we asked a person, have you ever traveled? Have you ever tried traveling in a bus? That guy said, I want to try acceptance first, that they let me inside the bus, right? So this was a question that he answered, right? And this is one such question, which many people are still finding answers to answer. So it also matters because, as I told, there are over 26.8 million people with disabilities. That's roughly close to 2.6 crores in India, and in which 54% of them are lacking literacy, and 69% of them are residing in rural areas. So you just imagine, I will also tell what is the human resource that is getting converted to deal with this people. When 69 people are residing in the rural area, how much of workforce we need to go and sit in the rural places, right? So this is the big question that we all have to answer. Can the physiotherapists, occupational therapists, and the so-called speech therapists, can they go and sit inside the rural places? Mostly we are not able to, right? Imagine, when we are being sent for this 2 years of sponsorship obligation to the places where we go and work, we keep saying that the places are having very less resources, right? Now imagine 69% of the disability population are sitting in the rural areas and they don't have anyone to look at. And how big the demand to get these services, right? So this is one of the things why where, the people with disabilities themselves started taking it into their hands. If you go to any of the villages or any of the, the smaller towns where you can find people with disabilities, you can see at least one organization that is being led by people with disabilities, which is providing the rehabilitation care now, right? So this is how the shift is happening. And do they have the physiotherapists, occupational therapists? No, they don't have. Whom do they train? They train the people with disabilities themselves. And we also keep raising the flag saying that, hey, it is a threat for our profession. It is definitely a threat for our profession. How are we going to deal it? That is something that we need to talk about, rather than saying that I will not go and I will not even go and sit there. But still, I want to ask the question, why, people who are not having adequate trainings are doing such services to the people with disabilities, right? So that's what is mattering. So this is the gap that we have. They say 95% of the gap in the allied health professional requirement for the current demand has not been met within India, right? In which, in that 95%, they also say 98% of the rehabilitation professional gaps are still remaining for the demand that we are having, right? So this deficit is coupled with the ecosystem to push the DPOs themselves take an action that they want to do something for their fraternity. That's where the CBID is holding a bigger role. And that's where the CBID is telling that we want to do something, right? So this is the vision for the future. And they say that the people will start to get involved even at the governance level, and they themselves are becoming the donors. So I can tell some examples where the disabled persons themselves are the donors. They might not be donating money, but the way that they are raising funds, you should learn from them. If we have certain people who just organize a camp with just the phone calls, right? So they also are involved in donating. They're also involved in supporting the programs, and they're also involved in the local changes that has to happen. So CBID basically removes the barriers that causes exclusion and discrimination in the communities. So that's where the shift is happening. Earlier, like able-bodied people, like they were trying to rule the NGO sector, but now it is changing. So we ourselves, as David said, like we ourselves are running an organization, but we ensured that at least more than 30 to 35% of the people whom we are recruiting, they're all people with disabilities. And the program heads, whomever we are trying to recruit, they're all people with disabilities. The reason is they know the actual ground reality to understand what got to be done, right? That's where the change will also start. And they also say that their local groups, whomever they are trying to mobilize, the local groups, whomever they are trying to do certain programs, they are going into the nitty-gritties where they can also get the monitoring and evaluation part. A disabled person says, last month I have accessed this many rupees from the government, and these many people are getting the pension, and because of this, he is able to even pay the school fees of the children. Because of this, he is able to go to his work and get the daily wage, right? So they come to that particular nitty-gritties and say that they are able to do the monitoring and evaluation part also. So CBR is not dying. It is basically evolving into a different strategy, right? So way back, many years back, we used to say that CBR was a dry subject, right? Just to give you an example, when I used to study, I want to very openly say, and I think most of my teachers are sitting here, I failed in physiology twice, and that was the toughest subject for me, right? I failed in PT cardio once. I hated it. But later, when I just took the mark sheets when I was applying for jobs, I saw there is a subject called social preventive medicine. So that is the only subject that I top scored among all the 10 classmates. And I understood that this is my heart and I need to do something in this, right? Not only that, I started working, right, because the place where they sent me to do the bond, that taught me something, that the community change can change the rehabilitation also. Because we worked for the weavers community, and we were just trying to see why the weavers community women are dying. And then we understood that it is not the problem of the women, it is the problem of the men who is getting into the alcohol addicts, right? So there is a different shift that keeps happening, So all I want to say is that the process of CBR might be changing, but there is something that is evolving in the recent times, which we have to be more aware of. I want to share a few case studies which all these three people whom I'm talking about are the ones whom I have worked with. And you should see that how they have changed the view of disability. So NS Hema, she was a 17 years old girl when she was affected by polio. She is no more. But I have a very fond memories working with her as she from where, I have understood what rehabilitation could be, right? One simple example that I want to say, we were struggling to get the children to the therapy room, right? And she was just observing it in the wheelchair, and she was just looking into what was happening. And there was a worker, barefoot worker who was there. She started screaming at the children, but she never told anything. After those children went back to their school. It was an inclusive school, by the way. So after those children went, She didn't do anything. She came back in the evening. There was this hand railing that was there. She started tying bangles to that, and she started tying chimes to that. And the next day, the children who refused to come to the classes, right? They came in the wheelchair, they came with the crutches, they came with the AFOs. They were touching this and it was making noise and everybody were passing by touching it. So they were entering the classroom. We were all just awestruck and we were looking at it. We were able-bodied. We couldn't understand what the child requires, but the person who was sitting on the wheelchair, she was able to relate what the child requires, right? And not only that, she was a person who has impacted over 6 lakh individuals, which was published in one of the journals. 6 lakh individuals with disabilities. And moreover, you go and ask any NGO in Karnataka, they will know Hema. Because one or the other way, she would have ignited that light in them to start their NGOs. And most of the NGOs are run by the people with disabilities themselves. And her skill development idea of recruiting the people with disabilities from the community and making them the horticulture specialists are still one of the most important training which was conceptualized even before RCA talked about it. The Rehabilitation Council of India talked about it, right? There is one more person. I don't know, for some of you, he might be a very well-versed person. His name is Vinayak. He was 21 years bedridden. And this person, he was identified in a camp in the remote villages of Kanyadi. But again, like when we were working with APD, and he was sent here for rehabilitation because back then in APD, we didn't have adequate facilities to take care of him. We sent here to CMC Vellore. And this person now is running over 3 self-help groups where he is trying to help the people with spinal cord injuries. And he himself is running an organization called Shevadhama, where they are trying to, I think Sharon might be knowing, and because she is working with him probably closely also. So he proudly says, the one who was staying in one room for more than 21 years, in each and every year is now traveling at least a few lakhs kilometers to go and visit his peers and gather them and ensure that he's running the preventive healthcare camps for those people with disabilities. Imagine the way how the push of CBID has improved the lives of quality of lives of people. The last one is Madhu Singhal. I think she is also somebody whom you might know, a lady with visual impairment. I have not worked with her, but I have tried interacting with her for many, many reasons. She was born visually impaired. She pursued her BA and MA in Hindustan Classicals. Now her NGO, which is called Mitra Jyoti, she provides employees to IT companies by training them in IT profession and also ensuring that they are trying to have the capabilities of accessing the computers. And each and every year, she ensures that at least minimum of 500 to 650 people with visual impairments are getting jobs. That's her organization all about. And she was also awarded a national award for the empowerment of people with disabilities in 2008. So the reason why I wanted to talk about these 3 people, there are many, many people, but see the impact what they have created being people with disabilities, right? So this is where the shift has happened from a CBR model to CBID. These are the people who emerged in the last 20 to 30 years, right? So these are the people who are torchbearers, where they have just said that, hey, I can do even I am a people with, even if I am a person with disability, right? So I just interacted with all these 3 people. What is the toughest challenge that they have? Everybody told only one thing. They said getting professionals is the toughest job. And the solution that they give is, we know that we cannot get the professionals. We want people who can train the people with disabilities as professionals. But unfortunately, we are not having a curriculum. But good thing is, let me all tell, there is something called NEP, I think everybody will be knowing, right? National Education Policy that has come, which says that we can recognize the people who have already worked in the communities as per their years of experience. And we can also even say that these people are having this much of experience and they can also be certified. But it requires a lot of documentations and other stuff. So this is the other card that I wanted to show you at the last. The card that's like changed the entire scenario of CMC value. And here is also another card that has ensured that it trains people. And just imagine this card went to the community and it went and visited the people. But are we still doing that same? That's the biggest question that we need to ask ourselves, right? What if every Anganwadi worker was also a disability inclusion advocate? We have a lot of people sitting in the community. Anganwadi workers are the ones who can reach even to the last person, right? CBID challenges us today, practice medicine not just in hospitals, but in hearts, homes, and also each and every small village. With this, I want to stop it, and I think I completed it in 25 minutes.
The last two talks were the foundation of why I started and why there's so many graduates all over the world. So we really got to pump that lower. Number two, that is a place which has a pretty lucrative career. You can make enough money while providing the service. Lastly, this whole session was targeting students at CAV. So the first 4 questions are going to come from students. Either you ask question or I drive you on. How about that? Okay, let's go to the first one.
So I'm also a little bit scared about questions, sir. I didn't tell one of my greatest teachers is Abhi. He's my classmate. He knows how I'm scared. We both are clinical partners. That's how we started our career. So I'm very scared about question, but please be very soft on me.
To the students, the whole objective is to build a relationship across the day. As you probably have seen a number of us here, a lot of people here from Bachelor of AE to Bachelor of It's a 4-year gap. The whole objective is to build cooperation between all of us. So do not feel scared, but feel more scared of people than you all. Okay? So who's going to start? Go.
I'm also scared. I think you can go and ask.
Start with Veena with all her enthusiasm. Not stop. Please.
When I was working with CPR, I don't remember exactly which year now, but they used to, according to the UN CRPP, you could no longer call people with, it was called differently able people. So you should never call disabled people, is what they were saying. So I was wondering when you were, because you were saying this is the present moment. Is it still a norm or not?
There are a lot of debates that keeps happening. They also said we should not call disabled people. They also said we should not call handicapped people. Right now, what they keep saying is keep the person first, right, and then keep the disability next. Right, that's allowed. But the problem is we cannot call them by they say that we cannot tag them with their disability. They say, oh, he's a person with so and so, a lame person, a blind person. All of them, what they try to come to say is that give them the dignity and respect what they require. I will not be going and calling a person unless and until, like it's a talk or the lecture that we talk about. We will not be talking the same language with that same person saying that you are a person with disability. I will also always call them with the name, right? That's what they expect. That's what they expect. Correct. That's what it matters, because over a time from the CBR till date, many things have changed. They say handicapped cannot be called, but it's all terminologies again. Whatever we speak at the end of the time, does it go to a person where, the dignity goes and reaches to that person. So I never talked in my Viva voice, sir. You can ask all my teachers. I have never talked in my Viva voice. Samson sir is here.
Okay, is the mic turned on?
And yes. And you mentioned 54.7% of disabled people lack literacy. Have you explored the concept of homeschooling for people with disabilities? Is there anything in the
Okay.
literature or work related to that?
So I just wanted to give you our own example, what we do. So I have not told what I do. We do work with children with disabilities who are orphaned, abandoned, or surrendered. So they don't have parents. So we do have this concept of homeschooling in the orphanages wherever they are, right? So we do follow a curriculum, which is very, very primitive curriculum that had been built. So homeschoolings are there, but as you said, when we go to the rural places, it's very difficult. Even still date, like it's very difficult for them to get them to the school or even to make them homeschooling. The reason being, the parents are not having that much of literacy to impart that skills or the knowledge to the child. So it's very difficult. We are talking about Sarva Shiksha Abhiyan, all that. Yeah.
It's a mic right behind you.
Is this concept of homeschooling being discussed with parents? Because see, many moms may just they may know how to write their name, but they at least know say ha tak. So if we can introduce that idea where moms teach the disabled children, at least the letters at home, when you're cooking for them, make a roti with in a particular letter shape, dosa or whatever. So is that concept taught to the mothers or fathers of the people?
So yes. You can. So one is early interventional concepts are there, but I don't know how.
See, actually, I was just going to say that only. See, we have these programs where we do work in the community. In Spastic Society, we take 1 or 2 qualified people also. But according to him, we can train persons with disability themselves to do this. Our program, what we call as early intervention, is basically training parents and caregivers. So we train them in all fields, whether it's OT, PT, or special education, or whatever, speech, etc. We train the parent and we follow them periodically. So they are basically home trained. So that is what is happening. I don't know the
So
number.
That's called early interventional.
No. See, how is the smartphone going to help? No, her question is very basic. Whether the parent can be taught to train the child, teach the child. I am saying yes.
Yeah. So basically, the early interventional plans that are.
Always, literacy is always on the higher side in the state of Kerala. So when I just noticed this number 54.
This is entire India.
Concept of literacy training, emphasized
See,
with the parent.
These programs are only according to what the child needs. So if the child needs literacy, the trainer would train that family or whatever to go into literacy. Depends on what all they need. Sometimes the multiply handicapped might need a little more than the others. But if the child basically has to be taught to write her name, or one of the basic thing which we teach children is their village, their name, the parents' names, etc. to write.
So in short, Vidya, to answer your question in a very simpler way, homeschooling in the disability perspective, it is called early intervention and early educational programs. So they're all taught to the parents and they try to teach them. That's it. People who don't have parents, then, we try to do it through this people whomever we are training.
I think the more you sit, the more sleepy you get. Let's all do 5 push-ups each, so that we all wake up. Okay, before you do that, give a loud thumb to a big man who can tackle. And for those of you who don't know, look out for the organization called PACT, which was started by Reuban, and all the way. So this is something our own alumni started all the way through, like the previous speaker as well. So these are all something that you should look at as a potential career. Because not only does it give you a satisfying life, but also gives you a living to make him up. Over back to Preethy.
Thank you, Reuban.
Okay. Yeah, let's go. Okay, let's go right here. Let's go. Okay, let's go.
Thank you, sir. We'll move on to the next session. It's translating research into practice, a guide to budding clinicians. The speaker is an associate professor in the Manipal Academy of Higher Education. To read about his resume, I need a separate CME. So before wasting time, I'd request Abraham S Babu to take over the.
All right, good afternoon. So I think we just had some good entertainment now. You wouldn't have thought to look at me. I'm nowhere near fit. But anyway, so it was entertainment for me. But it was wonderful to see the energy. And I think what we are starting to see coming through is that you have clinical knowledge that you gain during your course. You have a very different component of what is being implemented and what you do in clinical practice. And then you find this big gap that exists between what you learn and what you do. Just for me to understand the audience other than the alumni, how many of you are in your final year right now? Okay. Okay, your third year? Your pre-final year? Okay. Your second year? That number seems suddenly much larger.
I get the feeling like nobody is sure if they are there.
There or not there. I know. Well, it's MGR University. We understand. And first year? Okay, wonderful. So, all right. Well done. So I understand that it's a wide range of things. So I know for the final years, once you started clinics, it's going to be a little different. But let's see if we can run through this session. Okay. So I must start by acknowledging my PhD student. A lot of the slides that I'm going to present a lot of it is based off her PhD synopsis. So I acknowledge her for her contributions. So before we start off, again, a show of hands. Do we really need to translate your knowledge, your practice, or your research into practice? Yes? Not necessarily. Okay. All right. Okay. All right. So is it needed then? So the answer is yes. Okay. How many of you say yes? Okay, wonderful. You want practice to influence research. Okay. So okay, so that will take me a little off track, but listen, let's not go there. Now, how many of you need this? How many of you think you should be doing this? Thinking about implementing research into practice. Okay. Now the next question, how do you do this? Just do it. Nike. Okay, just do it. Put on your shoes and just get it done. The next question, do you think it is easy to do? All right.
So you have a mix. So again, I'm trying to just probably give some ideas out to you. Overwhelming, yes. It is easy to do. Okay, all right. Okay, let's go on. For Charles, sir, so this was something I did in the morning just at the end of Charles sir's talk. So is it fascia? What are the clinicians talking about? Is there confusion? Is it evaluated? Is it validated? People are still confused. So this is just one example. And I think we heard a lot about that. But eventually what you come up is, there is a big gap between what we know and what we practice, right? So I haven't had the privilege of working in an OPD setting or in a musculoskeletal setting for the last maybe nearly 20 years. I do only cardiorespiratory PT and I do only cardiac rehab, which I'm sure none of you have much interest in. But I'm here to tell you that that is actually a very exciting field of work, okay? And you can implement a lot. And the same thing translates to every field and every specialization that you work in. But it also requires you to assess why that gap exists. So it's not enough that we say, okay, we've learned this, we don't do this, and walk away and argue about it and be vocal about it. The question is, why does that gap exist? And I think the last two talks have actually told us from a community perspective, there are challenges. A lot of those challenges exist even when you're in the hospital. Okay, and it is daunting to try and think of bridging the gap in the community because it's a very large divide. But you can always start small, start even at a center and move it out to the community so that the impact is still at the community. And I'm here to just say that you can do it in very simple ways. Now, this is a lovely paper that's available in the BMJ. It was published in 2008. Dale Needham and colleagues wrote this paper out on how you can translate evidence into practice. And it's a very simple model. I'm just going to run through some of the steps with you. A lot of it is what we may be doing, but we don't realize that there's a structure to it. Okay? And we're going to try and see how that works. The first picture looks daunting. Forget it. I'm going to break it up into very small things for you. The first part is summarizing the evidence. What do we know? Is there evidence at all? Is there no evidence? Now, does that mean that if there's no evidence, we don't do it? And I think there was a little bit of conversation Charles Sundarsar and I had. The absence of evidence is not the evidence of absence. It gives you an opportunity to think about something to do. So obviously you would do your initial search of PubMed and Cochrane. And the reason I'm putting these very specifically for the students especially is it is not Google. Google is not your teacher to answer this question. Neither is ChatGPT or Copilot. Okay? This gives you a little more robust information, a little more credible information. But just because it's on a database doesn't make it credible. There is still something you need to do. You need to appraise the evidence that you find. Is it good enough? Is it truly good enough? Just because I publish something doesn't make it good. I can publish rubbish if I write well and I can convince my audience, I can get it published, but it may not be good. Okay, there are various checklists available. The CASP checklist is something that can be used. It's used quite extensively for various study designs. I urge you to look at it when you have time. Synthesize the evidence. Can you pool the data that you have got together? We all look at it only from an output. We say, okay, let's pool the data and let's make a paper out of it. You can still do it as part of an activity that is there. You have, for those of you who are studying here, you have access to people with immense expertise in systematic reviews, meta-analysis, who can really help you out. And it is go beyond the department. Your institution is here for that. You know, move beyond the four walls of the department, reach out to those who are there. I can guarantee you it works wonders. And I think in the evening when I talk about it, you will hear how moving beyond those four walls actually was the start of my career in research. And once you've got some of your information together, think about it. Can I use this? Can I actually implement some of this? Is it feasible? So we talk about different forms of interventions, but is it going to be feasible in my setting? Think about it. For those of you in your final years nearing internship, when you go to your bond, don't just think that, oh, I learned this in Velo, therefore I should do it here. No, think about it. Is it feasible? If it's not feasible, find an alternative. And that makes you even more creative and makes your bond even more enjoyable because you'll find something really fascinating there. Now, if you have summarized the evidence and you've looked at all of that, look at the barriers to its implementation. Because you are going to hit roadblocks. Okay? The first roadblock is you yourself. To understand that I do not know something and I need to find evidence, or what I'm doing is probably not right. Just because we do something 100 times incorrectly doesn't make it correct. I'm still doing the wrong thing 100 times. So you need to be able to look at it and say, okay, can I change that? Do I need to change it? Do I need to change my practice? If you can overcome your barrier, you can work on the others. I have mixed various components of quality improvement strategies into the talk because it helps you understand how you can actually make that change. And if you actually look at it, use it as an exercise. Just think about one intervention. You want to change it for one of your patients. What is the evidence that's there? Is it effective? What are the challenges that you have in implementing it? Just draw a fishbone. The head is where the effect that you want. Everything else in the middle are challenges that are going to be there to prevent it. And what can you do to mitigate those challenges? It helps you think and plan in advance. And remember, what works for me will not work for you and vice versa. It has to be contextualized to your setting. You need to measure performance. Okay. Now, I think the little break that happened in between was a good example. We all think we are fit individuals. Only 2 people came forward to actually do push-ups. I don't know who did more. But that is measurement of performance in the very simplest of form. You need to measure something to say that you are doing better. I can sit back and think, oh, I'm fit. I would love to think that. Oh, I'm fit. I could have done that. Make me do it. I don't think I can do more than 2. But unless I measure it, I do not know. So it's very important that you select and test the outcome measures that you use when you want to translate your research. Research will use fantastic outcomes, I can tell you that. Simplest of simple, the numerical pain rating scale, for example, or the numerical rating scale for the change in symptom. In our hospital, a quality indicator used is the number of patients mobilized out of bed. It's as simple as that. We think, oh, we have done our work, everyone we've treated. How many of them did you actually get them to stand and walk around the bed? Think about it. If you had a target, do you think you would reach it? Because you know someone's going to audit that at the end of the year and end of the month, and then ask you, why is it that only 40% of your patients are moving out of bed? Or why is it that their symptom rating is so high in spite of your therapy? If you claim your therapy works. 2 things. Revisit the therapy that you're administering, the technique of administering, and whether your outcome is sensitive to pick it up. Don't do long scales. Those of you in your final year, are you doing a research project or starting to think about it now? Yes? Have you been asked to collect outcome measures and think of a scale? Yeah. So I know one of your faculty may talk about core outcome sets in a while. So those are one way of doing it. Okay. But think simple. Do you really want someone to spend half an hour, 45 minutes to answer a set of outcome measures? What can you do quickly? What is still valid and reliable? And once you've got that, first understand where you stand. And this is the hardest part for any institution or department to do, because we don't want to know exactly how we are. We think we are doing great, but we are actually not. I take this line from the AHA, which says, you cannot improve what you do not measure. This is used in a lot of our CPR training metrics. We measure a lot of things, but those are used to feedback and improve on quality of resuscitation. You may say resuscitation is saving a person's life. Why not in the quality of care that you give? So know where you are and know where you want to be. It's very important. That gives you direction. It is important to use a model to implement it. And there are various models. This is known as the 4E model. which includes evaluate, engage, educate, and execute. Okay. Very simple stuff. And then you want it sustained, you endure and you extend. Okay. So it's not, it goes beyond. Simple other models like the plan, do, study, act is another way to do it. There's just circular activities that you can do it. It doesn't take you a long period of time. But all these processes help you implement evidence-based strategies into your practice with a strong methodological basis. You can't take research out of what you do. There is a component of research in everything that you do. Shopping on Amazon. Do you do a systematic search? You use different keywords? Yeah? What do? You compare. You look at it. You're very objective. And then you say, this is a biased rating. This is unbiased. You have that. It is science. It is research. So you cannot stand there and say, I will not use research in my clinical practice. It is something that you have to do. 2 case studies. One is a long case study that's still ongoing. We are not done with it. Okay. So this started in 2008. And this is where we started looking at early cardiac rehab in acute heart failure. So I'm here to also tell you a little bit about beyond the world of neuro and musculoskeletal sciences. And in 2008, when we started planning our research initially, heart failure in patients were all excluded from exercise trials because they just thought it was too unsafe. Cardiac rehab was nowhere near existent in India with only 3 studies published at that time. Well, we decided, let's see, because we think early exercise training could have some impact. And we went ahead and conducted a small randomized trial on 30 participants. We found improvements in functional capacity and we found improvements in quality of life. So these are individuals who received an early in-hospital phase followed by a home-based cardiac rehab phase. Okay. So like I said, it starts in the center, goes into the community. You need to still translate it. What did we do next? Well, our cardiologists were very happy with what they saw. Their patients were doing well. It became standard practice. This is at our center. I'm not talking about all over India. India was still skeptical, still are. But we started doing it. We had a program that we've been doing, which we were running for almost over about 8-9 years, longer than that. And we then published it again because it had gone through a lot of iterations and corrections, both for in-hospital and for home-based programs. We then thought at that point, let's revisit it. And this is what we did in 2020. Let's see now, where does the science lie? Has it changed from when we started in 2008? We looked at it again and we found that, yes, there is actually a process that is involved and we can actually get involved with it, with each part having a specific aim. So when we looked at some of the data that was there, we summarized it and we found that there are a lot of missing parts. There was no clear criteria. And this is the work of my PhD student, Ms. Akila. And we found that there was a lot of variation in data. So we went ahead and did a Delphi study. We involved experts from all around the world. We came up with a mobilization algorithm for acute heart failure. We have got this published. We also finished our pilot validation of it as an RCT, and those results are to be published. So these are some of the things that we did. Of course, as you see, a lot of outcome measures, right? Now, why do we need all this? Again, it'll make sense a little later because 6-minute walk distance is one of the key variables that you look for in rehab with heart disease. 1 minute sit to stand as well. Tug, because a lot of our patients are old. You use that for assessing risk of fall. Quality of life, you have 2 scales. This is where you can think about how you look at how to translate your work. Does it require a lot of time? You want to do something new, there is literature, but when you implement it, is it going to take a lot of time? If I'm going to spend 45 minutes with the patient as against 20 minutes, I need to think about it because I really need to think about how many I can serve. Do I need more equipment? Can I manage with what I have? Do I not need any equipment? What is the process involved? What is the outcome that I'm going to get? And also do not forget, there is something known as acceptability of this intervention. Forget all of this that is there. What I want you to remember is how acceptable is your intervention. That acceptability is not only by the person delivering it, by the patient receiving it, the caregiver of the patient who is accompanying the patient to that because they know how many times they need to bring them back for therapy, the physician who refers your patient to you, How acceptable is it? They may see the final result, but if they knew this is what you were doing, would they have, how acceptable have they found it? Involvement of all these people is crucial if you really need your program to be successful, especially when you're implementing something from research. Okay, I'm just going to skip across all of this. This is all the results that we found. And finally, what we did come up was a framework. This is used in public health for implementation research. This happens at large scale across the population, across countries. And this is known as the RE-AIM framework. Okay, so we are looking at the reach, effectiveness, how much can it be adopted, what are the challenges to implementation, and how do we maintain it? We have come up with barriers and solutions for them. And this is the basis for a large implementation multicentric trial, which we are now starting to work on. Okay. So when we talk about how we change our practice, remember it starts from a very small thing. Going out of your comfort zone, doing something that everyone says you cannot do. It starts right from there, actually. Because you need to question the science. Science does not evolve till you push that boundary. You need to be able to push it. What brought us this success was a very cohesive team that involved working with cardiologists, cardiovascular technicians, nurses, and their entire group. As PTs, we had to demonstrate high level of knowledge and competency. A lot of what you gain here gives you that skill. But remember, it doesn't end here. You need to build on it further. This is only the foundation. How you take it further is completely up to you. You need to be consistent in quality of services. If you have taken up the work ethic that you've learned here, you will achieve that. And involving as many stakeholders as you can. Now, this case study is still going on. We started in 2008. We are still not done. Now, does it mean everything takes so long? Not at all. We've been using exercise-based evaluations for a long time for all our cardiac rehab patients. And that's because it was projected in the core components in 2007. We've used the 6-minute walk distance. Are you all familiar with the 6-minute walk test? Yes? All right. Have you all done it? Have you yourself performed it? Okay. Have you had your patients do it? Is it easy? Suddenly silence. There are some who do very well. There are some you know who can do well, but just don't do well, isn't it? So it is a challenge. And we found that that was actually becoming a big challenge for us. So what did we do next? We thought, well, let's use something known as non-exercise based tests. And we use something known as the DASI, which is a questionnaire that helps us estimate exercise capacity. We required some adaptation because it was designed for the American population, but we were still able to do that. In 2025, the new guidelines were published. It came up around between November and January. And they talked about preventing preventing risk of falling and also targeting frailty. Forgive me for the spelling errors. And it was recommended to use timed up and go test, 30-second chest, 4-step balance, and burp balance. What did we do? Our postgraduates came with a paper one morning. We all sat together. We said, here is the paper. And they said, sir, we do 6-minute walk test. We do 1 minute sit to stand. We are not doing tug. Let's add tug. It doesn't take us more time. We already spend that much time with our patients. We can easily do it. We can do the 1 minute sit to stand and still mark the value at 30 seconds and 1 minute. We're not doing anything more. All it takes is the tug. And the tug does not take long to do. We spend more time with the 6-minute walk. We were able to incorporate tug and we implemented it the next day it came out. So you do not need a long process. Implementing research into practice is as simple as this or as complicated as the first example that I've given you. So take-home messages are, it is very possible to do it. Start small. Don't aim for the very large things. Make it very relevant to your practice. Choose the right outcomes or the quality indicators. And start with small quality improvement programs. And I think you will have success. Thank you for your attention.
Start with students. Whatever you thought, really relevant students. Not everybody, but more for you than that. If you feel you're kind of uncomfortable with that, just write on a piece of paper or save it to the meeting.
Yes, that's a question.
So even when we have standardized scales, measures, and even the methods are perfect, what the main problem that is affecting my study right now is patient participation. They don't show up. So how do I overcome that problem? Rest all is fine. My scale is fine. My outcome measure is good, but my patients don't show up.
I can have a CME only on this also if you need. The simplest thing is engagement. One thing that we have found really lacking is our engagement with patients once we recruit them. A lot of times, I mean, I can discuss this in our lunch to understand more, but broadly to just tell you, a lot depends on the engagement that we have. Sometimes we recruit and then we say, oh yeah, we're not going to do anything for you for some period of time. That becomes a challenge. The second is when we haven't understood the context from which they come and we enroll them into the study. So they may not actually be comfortable to come for all of that. And that sometimes is a challenge.
My sample group is a very niche category. So even though if the patients are coming and we even provide them with travel allowance incentives, they still don't show up.
Okay. I can talk to you more about that on a one-to-one basis for sure. But that's a very interesting question. And thank you for that.
Thank you.
Thank you.
Yeah, one person here.
Oh, wonderful.
What about all the women? Half the room is women. Okay.
So nowadays, because of the rampant use of AI, lot of AI, so in different fields, lot of research papers are poor quality. So how can we make sure that we have a good quality research papers so that based on that we can.
All right. So that's a wonderful question. And the question was about how do we ensure that we have.
Add something back.
Yep.
Instead of looking at it that way, look at it as, how do you define, how do you evaluate obvious reason?
Yep.
Because you start with the logic of ChatGPT. We are in that world. So how do we ascertain what is legit and what is false?
Yep.
What do we define by that?
Yep. So one of the steps that's involved is critical appraisal. And that involves you actually looking at an article very critically to look for certain salient points that are there methodologically and from the science of it. As far as if you go by checklists that are available, you do not miss out. When it comes to designing, you can use those similar checklists to look at your protocol and say, you know, if I was to look at my own study in an unbiased way, am I meeting all the checklists that are there? Am I able to tick off? If I can't, that means there's something there that needs me to go back and look at it a little better. So you look at your own study as though you were evaluating another study. I do that personally, and it helps me find out, you know, areas that just need a lot more work on. But there is a lot more in methods and outcomes that, again, I'm happy. It's a long conversation, but I'm happy to talk to you on that again.
For smaller centers, for smaller practices, because there are not as many hurdles to jump across to get there. In places like where I used to work here till very recently. So if I found something that I think could benefit my patients, for me to actually implement that in my clinical practice would be very difficult because I have to go through the loophole of, even though my supervisors, immediate unit supervisors were quite supportive, we had that loophole of going to the main practitioner. So the head of our team here is a doctor. So sometimes they are quite apprehensive of what we are suggesting, or they don't like being challenged. So some people take it that we're challenging their authority or what they're saying. So even though the research is good and it could potentially benefit the patient, these hurdles, how do we navigate this? Because in smaller centers, now I work at a relatively smaller place, so it's much easier for me to just talk to my boss and he's quite supportive. But in centers like CMC, for example, if I found something that I think could work and I take it to some people and either for whatever reason, I'm not able to implement it, what are these things, what strategies could I use to actually get there? Because there are a lot of good research papers and I feel we are lagging behind because we keep following age-old practices and we're not updating ourselves.
Yep. I mean, that's a very valid point. And it's not just a CMC phenomenon. It's there with every big institute that you work in or any institute that you work where there are multiple levels. A lot of it starts with you first ensuring you have the right people on the team as you start to work. And to form that team, it starts with you demonstrating competence at the highest level, consistency in your work. So it shouldn't be that I work well because I want to get that. I work with that because it's my passion to work in that area. It is visible. It is very visible. And once you establish that and you have laid the foundation that, I can do this well, that is when you go with the next thing saying that, can we just run this across the board? And can this now be done? Because unless you have done it yourself and you can demonstrate that this works safely and effectively for your patients, a clinician is not going to take it straight off. So you need to first build that base and have it with a good conversation with them, then take it up and then start thinking about research comes a little later. You first need your good clinical practice to be grounded. Once that is grounded, your work speaks for itself. It helps buy-in from your other administrators much easier.
Okay, with that, let's give a big clap for Abraham. I understand a lot of students are pretty anxious and kind of a little side to ask, but this is an opportunity for you to get over it. Because then your life can tell us better. This is a very protected environment. It's easier to do that. If you can't do it, please use the lunch break to do that as well.
Thank you, sir. The last session for the day is, the last topic is value of theoretical frameworks in practice. To speak on that, I'd like to invite Dr. Preethy Samuel, Associate Professor, Wayne State University, Detroit, Michigan.
Thank you. No, I think I'm good. No, I'm good. Hi, good afternoon. I know it's the last session, so you can relax. I am a researcher. If I was talking with my researcher hat on today, I would have probably had a good follow through, just like the last presentation, because most of my life, what I do is my measure family quality of life. What is family well-being? For any intervention that we give families, irrespective of diagnosis, if the family is not stronger as a unit because of our home programs that we give, actually, I argue that maybe we have not done a good service to the family. That said, after my graduating with an occupational therapy degree in '98 from CMC, one of the first challenges that I took on was to start an inpatient mental health unit in Manipal, in KMCH Manipal. So that's where I started my journey of realizing the needs. The needs are an ocean, but I also realized how hard it was in a lockdown ward to actually start an OT department, right? Without access to families, it's so hard. And I went on to do my master's and PhD in sociology in the United States. And I realized how much harder it is to access the family. And without the family, all that we learned here in CMC in Vellore is actually, you feel like blind. Like I heard Mukti ma'am talk about how, that 1 year or 2 years you worked in US, it seemed like a disservice to all that we learned and we practiced. So that is why I care about, sorry, my slides. I care about families and family outcomes. So as a postdoctoral researcher, one of the first challenges that was given to me is, even in the US, most of our funded projects, federal or foundation, the first challenge that's given to us as the research field, as program evaluators, as community-based researchers is, okay, what good did that money lead to? And families will always say, we're very satisfied. We love you. Come back to us. And that was not good enough to our funders. So one of the first things I deal in my research world is, it is not just a measure of satisfaction. We need to know more. So really, as a researcher, I look at this construct called quality of life. Is quality of life just restricted to how satisfied am I? Like today, after this session, if we had a evaluation, you'll all be asked, were you satisfied with all the talks? Were you satisfied with the snacks? Were you satisfied? But much of my research focuses on looking at other indicators, which I'll get to in my presentation in a bit. Was the topic relevant to you? Is it important? Did you have opportunities to make a difference? How much initiative did you take? right? And then how much did you attain? And then finally, how satisfied are you? So I look at the nuances of quality of life. Is quality of life merely satisfaction? No, it's not. It's beyond that. And so when we approach families too, like somebody talked about the Karnataka group where everything is good, that they don't want to do rehab. When we work with minority populations in the United States, what we find is that sometimes we hit something called the glass ceiling effect right at pre-test before we do any intervention. And mind you, I'm a social science researcher, so I don't do hardcore institutional based, it's all community based what we do. We have social workers who go into the community, work with families, and we will ask them, so how did it go? But right at pre-test, they're satisfied with everything. And there are certain, especially our immigrant populations, they're just happy and fortunate, happy to be where they are. They never have complaints. And so that's a problem for social researchers. If at pre-test, you're already rating 5 on 5 on every question, at post-test, I can't show you improvement, right? And that is how I started working with this International Family Quality of Life Framework, which I'll introduce a bit to you. Again, in this kind of CME, we can't really educate you about everything, but we can introduce you to concepts that you're welcome to always dialogue with us. This particular instrument that I use is used in over 36 countries internationally. And whether it's rural Nigeria or rich Japan, we find similar findings, which I'll slowly get to. So yes, I know it's getting to lunchtime, so I have a lot of pictures. I'm going to talk about the value of theory in research and practice. We just talked about how Abraham showed us how at the end of a lot of research, they built theory, right? So I started with research in quality of life among people with intellectual disabilities, right? That's the population I focus on, like people with autism who grow older. I specifically focus on aging adults and aging caregivers in this phase of my research. I too started with young families. And yeah, so we're looking at, is there really any value for all the theory that you study, right? Do clinicians need theory? Do interventionists need theory? And the first picture I want to pose before you is that of a spaghetti or Maggi noodles, if you can relate to that. You try to eat a noodle a strand at a time, it's really hard, right? They're all convoluted. And what I'm arguing is sometimes for students, if you've ever taken case interviews, in history taking, has it ever concluded in that short time? Sometimes they just keep talking and talking. So what I argue is that we can have a convoluted type of thinking, right? The family comes frustrated. Okay, I want to get more PT services, or I want to get an AFO, I want to get this, and they're stuck on that thought. No matter what you say, no matter how balanced and holistic you want the treatment plan to be, the conversation doesn't go anywhere. So I call this cyclical spaghetti-like thoughts, right? That's typically your patient that comes. Or in the PT world too, some people will say, I remember my classmates saying a lot of jokes, like some are just focused on the color of their stools, or others are focused on their back pain. They cannot go through any other framework. That's called cyclical thinking. The patient in their mind has identified that this is the root cause of the problem, and you can't argue them out of it. So we go in cycles and we don't make progress, right? So that's your typical patient. In my case, because I work with families can get so stuck with, if I get OT, if I get PT, my child will be better. So then it's a question of how do I push past the waiting list, right? And nothing you say makes sense to them. Versus then I contrast it with this other picture called the waffle. If you've ever eaten waffle cones, waffle ice creams, I think it's familiar to you. No matter, and that syrup that I show there is like the heavy load of life that comes on, right? For all of us, life is harsh. Things happen to us. And now let me tell you my personal style. This is a paper that's published in the Journal of Policy and Practice in Intellectual Disabilities, which you can look at on your own pace. I talk about these two patterns of thinking. So personally, I am a mother of 3 children, and my oldest son is on the autism spectrum. He's 23 years old. And my own life, and the reason I do research is partly because of my personal family challenges, right? I always thought I'd be a clinician, who would somehow in some way figure out family-based practice. But turns out that my home is my clinic. As a clinician, it's my home first, and then advocacy is part of it. I'm soon always attracted to other parents come to me. I'm not attracted, they're attracted to me. And then I'm always providing services. So as a clinician, I'm constantly doing family-based support, first for myself and then for others. So from all the talks today, I heard a lot about the person with the disability, them being the center. So this whole talk comes to you as a family caregiver, more than as a therapist, right? So I have found that sometimes in my own life, I feel like this. From morning, I'm getting phone calls from the school district, from the therapist, from this, your son did that, your son did this. My life was like this, that I knew I couldn't function as an outpatient clinician or an inpatient therapist. So I remember after my PhD writing to my first mentor that I'll just come and volunteer because I need a break from navigating for my son. I need a break from being a clinician, right? And somebody asked about the homeschooling. I don't know. I'm not the kind who would, because all of life, I'm always teaching him anyway. So to imagine that even those few hours that he could go away from school, go outside of the home to be in a school was to me a blessing. To me, that was the greatest respite. So I didn't want to take that on. Not that schooling is the perfect solution. As some of you listen to me, don't think of me as the coming from the West with all the solutions. Yes, we have access to services, but services come only to the most, in fact, I use this metaphor called Doberman with lipstick. You know, the Doberman dog, right? And that's how usually moms with special needs are, right? We call ourselves Doberman with lipstick. It's a quote I got, a qualitative research quote that I have from one of the moms. That's how we feel. You have to fight, fight, fight to get services, right? And so like one of the studies I'm doing now using the family quality of life theoretical framework is we are doing a scoping review on immigrant families in the US, right? So many of our populations are not even represented in the research. Much like your villages here, there are hidden families even there. The Bangladeshi community, there's Arab American communities where they don't understand the service system. It's almost like they're living in rural Bangladesh in the United States, right? So even the most educated ones with knowledge of resources, we struggle to get resources. So if you don't even know how hard it is, you're completely forgotten by the system. So don't think of me as here she comes from the US with access to everything, not necessarily. I find, in fact, most of my research that's funded federally is for the underserved population. When I say underserved, somebody asked, how do you recruit patients? My first study that I was funded by the National Institute of Disability Research and Rehab, I proposed to interview 150 African-American families living in the inner city of Detroit, which is a high crime area. They are underrepresented. Most of our research on family caregivers and people with disability comes from the middle-class, white, Caucasian population. So the reason I got the funding was, one, I said I'll validate a family quality of life scale. Second, I said I'll do it in Black Americans. So how did I get the patients? They are not going to come to me. If I do online surveys, I'll again get the middle-class white women, right? So I would drive to these school districts, park there, and get the moms when they come to drop off the children, or work with the school principal and make sure when they come for their IEPs, I'm there and I'm collecting the data, right? So sometimes you have to enter the community, you have to build trust. Again, you can't just walk into their homes. You have something called gatekeepers. You have to build connections into the community. With the Arab American population, we've found, especially our Bangladeshi Muslim population, you have to go through the men. You have to first go to the mosque, build their trust before you even try to talk to the women, right? So it's all different strategies. You have to understand your population. It's not your research question that matters. It's about how much you get their buy-in, especially for niche populations, rare diagnoses. You find one advocate with a rare diagnosis, soon you'll get connected with many others. So what is waffles? It's compartmentalized thinking. Yes, I have a lot of concerns. If you've looked at a waffle cone, it has many dips, right? My life too is like that. I have two other neurotypical children who have their own set of needs. I have a 23-year-old who's on the autism spectrum. I have a 19-year-old who has his own attitude issues, which is developmentally very normal. At 19, he thinks he's conquered the world. He doesn't need his mom. But he does need us to pay the bills. So we deal with those attitudes. Then I have a 16-year-old who is figuring out high school. Then I have a husband who needs me. Then I have in-laws. Then I have my parents here I'm caregiving for in Kerala, which is why I'm here. So you have all these. That's my life of waffles, right? And syrup is pouring. Yes. Yes. And our class group, so a lot of people ask me, what do you do for do you go for counseling? I said, no, I actually have a class WhatsApp group. That is my therapy. So we find the cheerleaders in our life. Honestly, I can tell you our batch has been a strong source of support. So you find your cheerleaders, you go on. I mean, so many times people have recommended yoga, deep breathing. I said, I think I'll have more stress doing it. I'd rather laugh at some of their jokes and I'm better off. So you find what works for you, you do it, and life moves on. So as the syrup is going, you learn to compartmentalize your thoughts. And what I'm arguing here is the family quality of life approach offers you that lens. So you're not looking at a big muddle, but you're looking at life and its stresses in its compartments. So what is family quality of life? This is a picture taken a few weeks ago with my immediate family, with two of my husband's cousins and their kids, right? We traveled to Yellowstone National Park. This is a trip we've been planning for more than, I don't know, 10 years. So how did this vacation finally happen? It's not because I don't have money. We can book and go. We needed the right group of people. Honestly, it's the right group. You have to find people you can travel with who understands our son's challenges. Finding that right group of people, and even if you remember nothing from my talk, remember this one thing: the next patient you see, whatever be the condition, what are their informal support networks? Who are the people they have that they can rely on for just to have fun? Like I said, my class WhatsApp group is my emotional support, right? Who are the ones who will offer you practical support? In this case, I needed a group of friends and family who will practically be there when my son has a meltdown, that the vacation doesn't turn out into a shouting match, but we actually enjoy it, right? So it took us years of planning. So I put that picture there to define what is family quality of life. It's defined as the extent to which family needs are met, how much we actually enjoy each other, and whether family members have a chance to do things that are important to them. Traveling is important to my son. He loves getting on an airplane. He loves going on a bus, which is why every year I bring him to India, except that I can't do too many talks like this because his needs are priority. So I missed my class's 30-year reunion last year, which some of them are still mad at me about, but it was not practical. But this summer, I just had an opportunity to travel alone, partly because of my dad's sickness. So life happens, you embrace it. So I'm able to think like in a waffle rather than if I thought like a spaghetti, I'd just be fixated on Ben's challenges and just retreat in my shell, not interact with the community and not focus on what my family needs, right? And this is how usually a lot of parents are. They kind of crumble and shatter at that one point. They're not able to keep it all together. And sometimes as therapists, we add to that breakdown. Right? I learned this lesson in Nambikan LM and working in my internship with a family. I was busy pounding on them the home program while she's staying in-house, telling her, why didn't you work on the head control last night? Why didn't you do this exercise? And she broke down in front of me saying, listen, I didn't even sign up to be a mom. I'm a young IT professional. I just became a mom. And now you're telling me to do all this? I don't want to do it. I opt out. And I didn't know what to do as a young intern. That's when I realized, unless you strengthen the family, it doesn't matter how good your home program. Now with AI, you can even generate really good home programs. But if you don't understand where the family comes from, who are their cheerleaders? Like I said, my class group is my cheerleaders. When I was doing my PhD dissertation, nobody understood the stress of all that, or even when I went through the tenure process of faculty, that's also stressful. Sometimes you have to reach out and have friends who are completely different from your world. But at any given time, you need informal supports. Without informal supports, your quality of life is going to be miserable. So I'll keep repeating that word, informal supports, right? So this trip was a grand success because on the way back, my husband for the first time said, I think this is one vacation I truly enjoyed. We've been married for more than 23 years, by the way. Otherwise, our vacations sometimes just end up being argumentative. We are yelling, you didn't do that, you didn't do this. If you took care of Ben, we wouldn't have this meltdown, right? Again, is it these people individually? No. But you have to, every day you have to take new chances, you have to face life. So that's family quality of life for you. So what is quality of life? It's a long-term outcome of any intervention you do. Unlike short-term outcomes like caregiver stress and burden. You saw the battery that Abraham showed you. Similarly, we have a big battery of stress, burden, patient well-being, family well-being. But more than everything, look at quality of life as strengths, challenges, and desires. Every family has strengths. As a therapist, if you cannot describe the strengths of your family program will not work. Your home program will not work, right? For example, you might give like a home exercise therapy program. Like in Chad, we discovered when we went into our Chad postings into the villages, we would locate through rapid identification, couple of moms, right? So sometimes the only thing we left behind at the end of our 1 month posting was making sure the 2 or 3 moms in that block knew each other, right? Introducing them to each other and this concept of shared care, right? Maybe they take turns watching their children while the other mom went to work and make her money, right? So, okay, so at least the income loss is only once a week rather than every day of the week and them hating the child and probably even thinking of euthanasia of the child, right? That's the other reality. Is there really quality to that child? Those were things we learned. Similarly, in the Western world, getting out and interacting, not just sitting silently. When you connect with one more family, you realize this struggle is not your own. So does your home program, whether in the clinic or outside the clinic, does it draw in people from the community to interact? So for example, when I used to take my son to therapy, they would tell the siblings to wait out. And it caused a lot of stress for us. My siblings thought Ben was getting preferential treatment, my older son, right? They couldn't get to play with the cool toys. You can imagine how SI clinics are. They're so nice, but the other two thought that I didn't love them. That's why they cannot go play. So I had to stop some of those sensory integrative therapy because it was breaking our family's, strength. So then I tried different therapists till I found one speech therapist who would actually involve the other 2 children. So she made it like a group. So including siblings in therapy. Maybe some days the mom doesn't have to be there. Can you bring a grandma? Can you bring an aunt? Can we train that person, right? Thinking out of the box a little bit. Maybe here we naturally do it a lot. In the US, it's more relevant because, it's a little different context. The family connection is a little less there. And again, always consider whether it's cardiac rehab, whatever your area, if you measure family quality of life, you will be able to predict who responded to your intervention and who didn't. Not everybody will respond because your intervention is good. Sometimes your intervention is the best, but they're not responding due to several things. Maybe where they are as a family, right? It's also useful in intervention planning. Okay. So what are these domains of family quality of life? Just look at this picture. I pulled the services block out. If family quality of life could be in this entire circle, these are the domains I talk about. We, as OTs, PTs, doctors, psychiatrists, MD, you name anything, social worker, we all fit only into that brown block. And we think that matters, right? We're all working hard. You're in the CME to learn one more strategy to improve the quality of your service. But I'm here to tell you that's only 1 out of 9 things that matters to a family. Do we have the power to change their finances? No. Do we have the power to change their health? Maybe indirectly through our therapy, right? Do we have the power to get them to go out and have fun as a family, leisure? Possible. If your home program maybe has a whole group setting for the entire neighborhood kids, maybe their home program should be that they go out and play with one neighbor kid. There you just impacted the domain of family leisure, right? Community participation. Maybe your home program should be that whatever, use the caliper, use the crutch, go to the library, check out a book. You impacted community participation, right? I can go on with stories on that, but in the interest of time, also careers. How many moms are taking career cuts on that? And what is the impact that's happening, right? Out of this picture, what I want you to remember is we are a very small piece. Like somebody earlier said here, I'm not here to tell you don't offer therapy. What I'm here to tell you is, can your therapy go into these other domains of family life, right? Don't think of therapy as isolated. That said, I'll show you from the examples. These are the I already mentioned this, right? Don't just think of satisfaction, think of stability, attainment, initiative. These are the other indicators of quality of life. So here's some quick lessons from a present project that we just finished. We have at least 5 publications on this. So if this is interesting to you, you can always look it up. We looked at older caregivers of adults with intellectual disabilities. knowing very well that many of them are aging, their own health is declining, and they probably don't have a plan of support after them, what's going to happen, right? So this project was simple. Just like some of our community-based research, we've identified peer mentors, meaning they themselves are older caregivers, but they're well connected with the local systems. We paired each family, each navigator had 10 families to work with, right? So it's something like that. We did a matching and they would work one-on-one with the families, have monthly groups, one-on-one coaching for basic things like how do you apply for Medicaid? How do you apply for, there's a lot of adult benefits, like some of the disability things you said, you know, how to get through those process. What is the right language to talk when you call them? Culturally also, they had to be sensitive. So that's all really the intervention is. It's a simple intervention. It was a 2-year funded project to support 100 caregivers, right? The primary outcome, like someone said, the funders drive your outcomes. They wanted to see caregiver health improve. So we measured caregiver stress and quality of life. Secondary outcomes was to improve the system. So older caregivers, we wanted to identify the gaps in the systems. So we are addressing some of their needs. Yeah, we're running on time. Okay, we're getting there. So so this, for example, is what we would do from our evaluation. Aside from the large scale evaluation outcomes on an individual level, we would show the navigator, this is where, these are the 2 domains important to them. These are the satisfaction opportunities, or these are the initiative. This is where the family is at. So they develop very individualized goals. And this particular paper will tell you how 5 out of the 9 domains after the 6-month intervention improved. And the key point is that yellow highlights 16% of improvement in global family quality of life could be explained by the domain of informal support. So if you get nothing out of today's presentation, the next person you meet, whether it's your patient or your friend who's going through a hard time, make sure they can pick up the phone and they have someone in their life to offer informal, unpaid support, right? That's, and then I wanted to just personally, I just have some pictures to show you. So where I am in my life as a social scientist, when I reflect, most of my life, I'm measuring family outcomes as a researcher because I'm a project evaluator on a bunch of studies. Second, I do look at predictors of family quality of life, not just for research, my own life. And the next one is that Doberman wearing a lipstick. Often that's my life. I'm a fighter. I have to learn to calm down because if you don't fight, you don't get services. And in terms of predictors, for me right now, for my son to be employed is my priority. And the next few slides are just to show you where I am in that. So yeah, out of all our years of research, what we have found is that others or informal supports, leisure and recreation, community participation, family relationships. Out of the 9 domains, these are the 4 that actually will impact your family quality of life. And this is based on research from more than 40 different countries and contexts. It's not services, it's not finances, it's not health. It's these 4. Just to tell you that whatever we do, unless we impact these areas for individuals and families, you're not going to see any change. And this picture again is from the same trip, but to show that Ben actually made all these t-shirts. So my other job, wearing my OT hat right now, which is also personally fulfilling for me, feel free to scan it and follow our Insta pages. Shameless plug to our business. But it's not just, it's also, aside from being stress relieving, I partnered with a businessman in Mumbai who had a company called Wear the Hope. So we became his branch in US called Wear the Hope with Ben. So we have a therapeutic media lab, if you all know as OTs. Not many OT programs in the US has a therapeutic media lab. We are one of the few. And we are upscaling it now with all these modern technologies. And at home in my basement too, I have one that I started it in my home. Because of its success, I was invited to start it at my workplace as well. So these are just pictures of our lab in Wayne State. I work in a program that's 80 years old, but many of our equipment were very age old, not relevant to today. So I'm upscaling the lab to more modern technologies to teach students to work. So we do a lot of t-shirt printing for the college. We do sublimation printing. We do laser engraving with some of the newest machines. So the whole point being, like we said, dignity, empowerment, bringing all that in first into my life, then into my students, and hopefully creating these places where people with disabilities can come and work. And just as a last FYI, with all the disability empowerment movements, what has been lost is these simple things. Like sheltered workshops are no longer funded by the US government because they say it's poor quality, they need minimum wage. But in the process, what happens is they're not doing anything, they're just sitting at home, right? So in a lot of this disability rights advocacy, we've lost some of the things we had. So like we use the cart example. We need to go back to the cart and reinvent it in newer ways. Somebody asked about the person first language. I want to address that too. The language we use is people with disabilities or my child with autism, but even that is changing now with the disability rights movement. There are people who strongly advocate for autistic adult. When I review papers and grants, the first question I ask is how many people in your sample reviewed this language and approved it? Usually the answer is no. It comes from a theoretical perspective. And really the theoretical perspective comes from the 20% who are high functioning adults with autism, who value their identity, but the 70 to 75 who have an intellectual disability don't have an input. I know my son doesn't refer to him as autistic. He refers to himself as Ben. If you go to our social media webpage, you'll say, I am Ben, I love to work, I love to keep you happy. He calls himself by his name, right? So again, you can't go on all these new fads that come. At the end of the day, you need to work to be happy. And that is where, for me, my family quality of life improves because of this business. I'm here, but my husband and kids are managing the other side of our business at home. And that's it, really.
Thank you so much, ma'am. Any questions?
Can you hear me? Yeah, it's not a question, ma'am, just the scenario over here. I think in CMC, especially because most of them are students, here we involve family during therapy and we have a lot of chance to interact. But outside, where therapy centers are involved, parents are not allowed inside the therapy hall. They don't know what is happening with their child. They don't even know what kind of therapy, and there is no instructions given to the family because they spend 45 minutes to 1 hour with us. The translation doesn't happen to the house. There are next group. Because now they are able to support, the therapy, they're willing to pay how much ever for therapy, but they don't want to be involved. They would like to pay you, but they don't want to sit and see because for them, that is their time of you take care of it. So because most of them are students, I thought, because in CMC, we always involve the parents and the family, and we kind of understand what we're discussing. But when you go to the community over here, this is two kinds of things that we are seeing.
Absolutely. And you have to respect both choices because I've been that mom too. When I take my son to a clinic, I don't want to listen to you advising me for the next 45 minutes.
Yeah.
So I've been there. So I think listen to your family. But the second group that you mentioned where therapy centers don't involve the families, if they want to be involved and you don't involve them, that's a big problem. There's in fact a very active parent group in Kerala that I've been connected with who have been suing these therapy centers, left, right centers, and many OTs have been the center of those where you make it voodoo and money making. That is unethical. But if the family chooses to sit out, sometimes you just have to give them that break and understand and maybe ask for a grandmother, ask for a friend, somebody else who wants to do it. Recognizing that that mom is actually burnt out. This might be the only respite she's getting, right? You have to work around it. And again, it's not a permanent decision. Don't group them because then they might have the energy on another day. So generally with families, what I say is treat every day as a new day, give them a fresh chance. They have a right to a choice too every day.
Hello. With the rise in automation and robotics and AI, a lot of low skill and easy to do repetitive tasks that most autistic adults would have preferred are being pushed out of the job market. So we are rehabilitating a lot of people with disabilities, but are the jobs we are rehabilitating them going to exist for a long time, or are they even economically feasible anymore in the current job market?
Is AI kicking, is the AI a problem for them? I don't know. I don't know the job market here. I know it's not true in the US. For me, some of the things I mentioned are actually disability rights advocates themselves have stolen opportunities for our kids. Like long time ago in the mental health world, if they did the last step of like sticking a tag, they got paid per government that they did, right? Now, because of rights and human rights perspective, they say, no, they have to be paid minimum wage. And so then, yes, they do bring in automation to do some of it. So I kind of have to agree, but I find I'm also involved in another technology project where we are using app-based things to, so one of the big things is in the housing, right? So a dependence on caregivers. So we are looking at how can we use technology to reduce caregiver dependence. That doesn't mean we're going to take away caregivers, but some of this repetition for some of the mundane tasks like doing laundry, preparing a meal, can an app walk you through the steps, right? That will reduce some caregiver burden. I don't envision a day that you won't need a caregiver or even for these jobs. Your answer may be yes, but I think there is still a lot more that they can contribute to. We can't blame AI. We have to embrace AI. So we can't afford paid help is highly expensive. In fact, I'm at a point where I get a lot of state-based support money for caregivers to work with my son, but finding caregivers is really hard, even though they are paid like pretty reasonably good, right? So finding people is always hard, but what you said, that doula concept is what we used in the MI Ocean study that I talked about. We handpicked older aging caregivers, meaning like me, I could be a peer mentor for a 5-year-old child's mom, right? So we do this peer matching and we pay the other person, right, to be a mentor. So that is really, that doula model is what we use in this intervention called peer mentoring, where you're paired with an older, more experienced family caregiver.
Says online. Sanjeev, sir, you're online.
Yeah, can you hear me?
We can hear you.
Yeah, wonderful presentations. I'm sorry I'm not there along with you all. I'm in the hospital. I'm at Ranipet campus. But wonderful seeing familiar faces. Ravi, a big hi to you. Just coming to Preethi's presentation, I think it was a very heartfelt presentation, more than a person with great expertise speaking. And I think it takes you to be one among those who you actually get to treat, where you understand the whole nuances of what it means to be a patient or a caregiver. And I really appreciate that, because I can experience that now, being a patient now in the hospital, and many things that I would like to see happening very differently. And this is something which I think, Preethy, wonderful that, a take-home message for our students and budding therapists is that everything that you do may not be successful in terms of treatment. Sometimes you actually are clueless to what to do, just like how you mentioned about the CHAD model and the CHAD experience. I mean, all of us have had these experiences where you really you're totally clueless. You came back empty-handed and you felt very incapacitated because of the fact that you could really do nothing when there was so much that you would like to do. And yes, so I think this is going to be very important, and this is something we're trying to re-emphasize with our own students now about the fact that, when you make a home program, you need to make your home program effective. The word effective is a huge word. Maybe we won't get into it. But coming, I think Abraham did speak about it, even did Reuban and Rabi about, there was a touch on quality indicators. See, one of the most important quality indicators in assessing quality and quality assurance is not just structural and performance indicators, which Abraham did beautifully touch on, but is outcome indicators. And I think that outcome indicator is going to be very, very important, which Preethy has touched on, to find out all that what you have planned and what you intend to execute and have made an attempt to execute is reaching the patient in the way the patient perceives it to reach him or her. Thank you.
Yeah, thank you, sir. And coming to the end of the session, the word of thanks. It's a both honor and privilege to stand before you today to deliver the word of thanks for the CME in this reunion. Before giving that, I'll just call all the speakers on stage. Can you just come and sit on stage? All the speakers for today, the CME speakers. And David, sir, please be on stage. First and foremost, we thank God Almighty for granting us this opportunity to come here together to continue the learning and fellowship. Our deepest gratitude goes to the organizers and coordinators of this event. Your meticulous planning, tireless efforts, and unwavering dedication have made this reunion not only possible, but also truly memorable. A special thanks to our distinguished speakers. Whose insights have enriched all of us. We are grateful for your time, expertise, and valuable knowledge that you have shared today. I would like to call Andrew, sir, to just give the mementos for the speakers. First, Mr. Charles Premkumar Joseph, a batch of 1994 PT. He's a founder and consultant of Charlie Spine Clinic. Next, Ms. Mukteeshwari Bosco, founder and CEO of Healing Fields Foundation, 1983 batch, OT. Thank you. Next, Reuban Daniel Chandrasekaran, sir, head of Operation Pact India. Now we call Veena ma'am to come on stage to give the momentum. We call Mr. Rabindran, sir, the retired occupational therapist and former associate director, past is Society of Karnataka. Next, we call Dr. Abraham S Babu, sir, PhD in cardiopulmonary physiotherapist and associate professor, Manipal Academy of Higher Education. Last, Dr. Preethy Sarah Samuel, associate professor of occupational therapy, Wayne State University. Now I call Shivaram sir to come on stage to give a memento to David, sir. Thank you for coordinating the event, sir. Now I'll call the President, Margaret Christie ma'am, to give away the certificates for the alumni.
So you can take that. Just a few announcements. We have a rehab visit after this. The bus is ready. It's been a bit late. Bus will be ready in 30 minutes. So after lunch, all the alumni, please get into the bus. So in rehab, we'll divide into two batch of 20. We'll start from ground floor, PT and OT. After ground floor, we'll go to first floor. In the first floor, we'll sweep each other and then come to ground floor again. And tea is arranged in rehab at around 4:30. You can participate in that as well. And 6 o'clock is the official inauguration. Director and principal have said they will be coming. So please be on time at 6 o'clock. I request everyone to be there except students. It's for alumni. And also please, if at all you know, invite your colleagues and classmates working in CMC to come and join with us. For the certificates for students, I request one from each batch to come to the registration counter after lunch. 2020 Aaron, 2021 Angeline Ida, 22 Abhishek Pranay, 23 Ashin Benisha, 24 Alpita Kiruba, MPT Amisha, MOT Blessing. So these people, please come and collect your certificates for the class. And tomorrow we have a Ranipat visit in the morning. So bus will start from here at 7:45, 8. We have a breakfast arranged there, so please don't miss it. It's a miss for Optaa money also. So I request all to join us with Ranipat campus visit. Today after lunch, a few alumni has said that they want to talk to students. So after lunch, students, please come back for the short gathering. But the meantime, alumni can get into the bus and we will go to rehab. Attendance will be taken for this as well. Now, I invite Margaret Christie to give away the certificates of alumni. Because even I don't know who are the senior alumni, junior alumni here. So if I call up the names here, those who are participating online also will know who all have joined us here today.
Okay, this is just for all of us to know us by name, face, batch and degree. I'm not really very sure. So I'm not going to give a commitment that I'm going to say that. But yeah, we'll start with, in no particular order though. Andrew, sir. Mr. Andrew Babu. Yes, sir. Your certificate for the CMA.
Next we call Veena Rao ma'am on stage. Next Mukteeshwari Bosco ma'am. Rabindran Isaac sir. Abraham Samuel Babu sir. Charles Premkumar Joseph sir. Divya Bhushanam ma'am. Dr. V. Sundar Kumar sir. John Samuel sir. John Lysanias Daniel. John Lysanias Daniel. Reuban. Rene Joel. Samson Vedanai. Shivaram. Merlin R. Can you just introduce yourself, sir, like a brief introduction? As you come on stage, can you just introduce yourself?
Okay, my name is Abraham S Babu. I've been with one of the cheerleading crowd as well. Very here, I worked here for 2 years in the student. Then I left for higher studies.
Merlin R. Rima Samuel. Babu Samuel. Mr. Winnie Johnson.
I'm Merlin R from batch of 1996. I have only one classmate with me for this reunion, Samson, and I'm working as an associate professor here.
Winnie Johnson, sir. For this section.
I'm Babu Samuel, batch of 1999 PT, and also known as Rima something.
Delicia Roshni. Vineet, sir. I think
Thanks a lot.
Delicia Roshni, ma'am.
Delicia from batch of 2009 and currently working on it.
Rita Janet. Sharon Matthew also confirmed.
Hi, I'm Rita. I am from batch of 2003 PT, sorry, OT. I have my batchmate, Preethy, my batchmate PT, and I have Jim Elliott, who's my batchmate OT. I work here as an occupation therapist till 2020 December in CMC. And now I'm working in Qatar. I think 4 years I'm working there in Hamad Medical Corporation, Qatar. Thank you.
Sharon Matthew, ma'am. Yarusha.
Hi, I'm Sharon Matthew, and I'm from the batch of 2008 PT, and I'm currently working as a manager for spinal cord injury in APT. Thank you.
Yarusha. Andrea R.
Hi everyone, I'm Yarusha, batch of 2012 PT. I'm currently working at the Duncan Hospital, Raxaul, Bihar, in the Indo-Nepal border. And it's a joy and privilege to be part of this reunion.
Andrea R. Jim Elliott.
And we are from batch of 2008 PT and working in CMC. Thank you.
Jim Elliott, sir. Vidya Koshi.
It's an honor to get the certificate from your own batchmate. That's really nice. Thank you, Christy. And it's a wonderful thing because I've bullied a lot of people during my stay here, and I've a lot of people who bullied me also. So it's like wonderful to see two group of people over here. And I worked in Bangalore for almost a decade, and then I worked in a place called Hubli in Dharwad. And I'm into a lot of businesses right now. So I take care of NGOs. I had the medical, educational, and the residential and vocational activities of a lot of NGOs. And also I'm the hospital administrator. I work as an administrative officer for many group of hospitals in Hubli. And also I love children with disabilities. So I take care of a clinic for pediatric neurology. So I keep myself really busy. Thank you.
Vidya Koshi. Sweeta.
My name is Jim Elliott. Yeah, she's the prompter of the batch. So yeah, thank you, Margusti, and Rita Chandrasekaran is my batchmate. Thank you, guys.
Sweeta. Vidya Koshi.
Vidya Kushi. I'm from the batch of 2002 PT. I'm a birth doula now. Being certified by the University of Hyderabad. I had my tickets booked to go to Raxaul, November 2007. My parents got me married instead, February 2008. And now I'm mommy to 8 children and we homeschool them. I've been on a totally different path from what I imagined in 2007. But biomechanics, I'm thankful we studied one whole year of biomechanics, because that has greatly influenced my birthing journey. And it's sort of a social influencer of the birth community of India, small networks. So if anybody interested in parenting, contact.
Ida Mary. Sweeta.
Hello, everyone. I'm Sweeta from North 4 batch PT, and I did my bond here as well. Currently, I'm working in College of Physiotherapy in Midnight, Chennai. Thank you, organizing committee, for this wonderful association and all this wonderful gesture. Thank you.
Ida Mary. Graham Samuel.
Okay, hello everyone. This is Aida. I belong to batch of 94. So basically, I came here just to meet my classmates mostly. So it's a mini get together because we're having. So basically, I'm in Chennai now, and I have a clinic called Genoway. So pediatric therapy services. Thank you.
Graham Samuel. Reshma. Reshma, please come forward. Sharanya M.
Hello everyone, I'm Graham.
from batch of 2017. I recently completed my service obligation at CSA Kalyani. I'm looking in for other job opportunities.
Advait Gulati. Saptika Karen. Saptika Karen. Mrudula V.
Hi, I'm Saptika, batch of 2015 PD. Ma'am is my grand foster. And I'm currently working as a product manager at a healthcare company.
Mrudula V. Kritika Jain.
I'm Regula V, batch of 2018. I'm working in business service application team.
Chris Lee. Chris Lee. Gratian Joshaya. Elijah Nissi. Elijah Nissi.
My name is Grayson Dosia. I'm a OT from 2019 batch. I'm doing my first year bond in Madurai.
Any alumni's name we didn't call? No.
Good afternoon. I am Elijah Nissi. I am from the batch of 2016 physiotherapy. I'm currently working as a musculoskeletal and sports physiotherapy therapist at Rapid Sport Fitness in Bangalore. Thank you.
Please introduce yourself. We'll give you the certificates later.
Currently working in Wayanad and
Yeah. Thank you all.